Well, good afternoon, ladies and gentlemen, mesdames, messieurs, mesdames, heren. Welcome to this afternoon session on artificial intelligence applications in the ICU. I'm not going to bore you with introducing myself, so I'll move on straight to the first speaker, which is Azra Bihorac from Gainesville, Florida, who's going to talk to us about applications in medical imaging. Azra.
Thank you, Ari. How do we fast forward? Is there a remote? Thank you. You are keeping it hidden from me. Okay, I need to use brain power here. Thank you, everyone, for being here for this really exciting session. My name is Azra Bihorac. I'm a professor of medicine, surgery, and anesthesiology. I lead Intelligent Clinical Care Center, a large group that does translational AI applications in clinical medicine. And I have this really exciting talk. I have no conflict of interest. I do not engage in medical imaging AI applications, but today I will be one of those YouTubers that will tell you about them, and I will give you my comment, my take on what I think about it. So let's review a little bit what is out there. I really try to focus on what is really actually available to us right now, at least approved by FDA in the United States. So what we will be reviewing today, I'll start with X-rays, like chest X-ray, one of our bread and butter imaging techniques, talk a little bit about CT, MRIs, move on ultrasound applications, a little bit more about visual pervasive video use that we do for our research very briefly, and then maybe future about retinal images that I think it's a really interesting application. So let's start with the chest X-ray. So first, I will review several applications of AI solutions using regular chest X-rays. The one is on-device AI. I think that we can think about category of on-device AI applications. This is currently approved by GE as a critical care suite. It comes on a portable machines. It can give you integrated point-of-care interpretation of the automation of certain tasks of reading chest X-rays. As example here, you can see for triage of pneumothorax or placement of ETT tube, the machine, the program by itself provide annotation, show you where the pneumothorax might be, and give you confidence of the model in terms of how confident model thinks this is the diagnosis. That will be on-device AI example. Now here's an example of the cloud-based AI. This is also FDA-cleared solution for AI-powered chest X-ray triaging solution. It's marketed towards emergency room applications. Again, looking to try to triage your X-rays in cases that require high priority versus low priority. Again, think about somebody coming with pneumothorax or pleural effusion in ER that might be missed because of the large volume of the patient. The page by itself gives relatively good sensitivity and specificity. None of these so far give a lot of details on how these models were trained or validated, and we can talk about it a little bit later. So this is one on-cloud AI application. And this is the third one that is a different concept. It's called DAS, Diagnostics as a Service. So here you have a computer-aided decision support that is connected to the device and is meant to be deployed in primary cares together with the imaging machine. So basically provides one stop, I would say, for busy primary care practice where you can have all imaging done on premises in your own practice without ever needing radiology. And then you can actually use automated interpretation of those images as a primary care physician. So that's interesting and unique in my opinion. So what's my take on these three X-rays? I would say the most intuitively, probably easiest to be applied will be AI on device. And my prediction is that a lot of companies who make these devices will just add this as a fluff, like just like your phone is now intelligence. It's going to come with the image. I don't think you will be competitive 2 years from now if you have a device unless you have AI on device. Everybody will want it. I think that the integration of the AI in the cloud is going to be a little bit more challenging. Some of you who works maybe as a chief information officer of the, it's a very hard to bring a new software solution in your workflow. It's not trivial to connect with the existing EHRs. So I think those are a little bit harder. I was was intrigued with diagnostic as a service. I think that's a fantastic solution for how we can address rural care and primary care, because we need scalable solution, and that I thought was a really intelligent one. So let's move on to CT. So here's a cloud-based AI multimodality imaging decision support. This is FDA-cleared AI-based software through the Siemens. It comes as a part of this, again, big solutions. The one that is cleared by FDA is for the chest CT, and it provides both chest, mediastinum, and cardiovascular system, both annotation, diagnosis, and some reconstruction and visual visual augmentation. This is also an interesting application, again, as a part of the Siemens. I think this will be just something that they will be bringing on. You can already see on their exploratory modalities. They have a brain MRI, they have a prostate, fuse MRI with ultrasound for biopsies, that you will see a lot of that coming on. Even a step further, you will see imaging with pathology brought together. I think that's the future. So this is one of the CT applications that we might see in ICU. This is now two neuroradiology. I think two companies that are currently FDA approved, and in a little bit of competition. I will show you, there is already first trial comparing these two companies. The first one is Viz Neuro. It has a cloud-based AI imaging decision support for neuroimaging, focusing really on a stroke workflow. You can see here large vessel obstruction is one first algorithm that predicts, or not predicts, but actually diagnose obstruction of the large vessel during the stroke. The company claims that they see almost 40 minutes reduction between patient arrival to the first contact with neuroradiologist. And also has incorporated communication between different specialties, including cardiology. That's very interesting, because some of these patients need some of the cardiac monitoring or some interventions. Another company is a Rapid AI, again, neuro AI imaging decision support, also FDA cleared, is Lumina 3D. This one not only does diagnosis, but also does 3D imaging reconstruction, so you can have this beautiful reconstruction of the vasculature in the brain within the minutes. And interestingly, here is the first time these both companies are running clinical trials and reporting positive results. The Viz AI has a single center study that they look at the deployment of their solution and found out that improved efficiency in terms of sending your patient for the cardiac monitoring following the stroke, and it was better than compared to standard of care. The dual study was reported in a recent stroke conference in LA, where they actually deployed both Viz A and Rapid AI and compared to each other to detect large vessel, and head-to-head comparison showed that Rapid AI was more accurate, identify more cases of LVO as compared to Viz-I. But if you look at this, this is just a report from the conference. If you look at the note, you can see here that 39 of the large vessel obstruction were missed by one Viz-AI, and only 3 by Rapid AI. It tells you that we still don't really truly understand positive predictive value, negative predictive value of these solutions. They are not really necessarily going through all of these things we talk about, model cards, rigorous testing, but they are there. They're FDA approved. It's for us to use them and to use them wisely. So in my opinion, I think that for a busy ICU, neuro ICU, again, this is a scalable solution. Neuro ICU is a very niche in many hospitals in America. It's very hard to get neurointensivists, and especially neuroradiologists. So having some offset in terms of workflows for the neuroimaging, I think might help on a large scale. In terms of the use of CT in a regular ICU, it would be interesting to see where it takes us. I'm not quite sure, but I think it's going to be part of the imaging that is offered to your hospital. So I think physicians will become very innovative. I think one that we all kind of see easily how this can be used is an ultrasound point-of-care device. Again, on-device AI for point-of-care diagnostics. This is, I think, of huge value for ICU. This is a handheld whole-body ultrasound cleared by FDA. FDA that is AI-enabled to quantify auto B-line counter. I can see this expanding to fast exam, to pneumothorax, anything you want. And one step further, I think we absolutely underutilize ultrasound in the ICU because ultrasound has so many more information than what we are seeing. And as this technology become more available, I think that we will start seeing very unique applications. Similar devices also FDA approved, Epic CVQ and Affinity ultrasound. These are actually automated tool for the segmented wall motion abnormalities assessment and can also be used for the mitral regurgitation volumes assessment. This is more cardiology focused, but I can see this in a cardiac ICU being used. So these are two currently FDA approved. There is a lot of research going in this arena, and there is a lot of companies that are trying to commercialize an FDA approved on a point of care AI-enabled ultrasound device. I think that's a big thing coming to ICU, and I'm really excited about that actually. A little bit on the research side, just this is what we are working on. We are working on using pervasive intelligence in terms of video and audios in ICU with the wearables and using these techniques to actually remotely and autonomously monitor patients while they are in ICU rooms. Because as you know, nurse, although she is supposed to watch two patients, most of the time she's entering data in the Epic. 80% of the time, nurses are actually engaged in electronic health records. So these tools now, we have a software that can actually completely identify patient in the room, track their movements. This is for facial action units tracking, so you can identify emotions or certain emotional states in the patient by combining this facial action unit in real time. And then in terms of the mobility, we can now track when the patient is in the bed, when it's out of the bed. Obviously, you can think about fall, but we were more focusing on like activity, what are patients doing during the day in the room, and whether they are engaging in activities. Similarly, this one of our software is now end-to-end full package AI toolbox that you can deploy and really through the video camera. That is very simple offline. It's off the shelf. Any in-depth camera and RDG camera can do this. So this is something we are continuing to work on. And I will close, and I hope I'm not late, with the retinal images. You probably read the paper that was done that used retinal images to estimate patients' age and almost any single medical condition for retinal images. And here's the two examples. One is to quantify hemoglobin from the eye. Another one is to predict cardiovascular risk factors. Besides telling you how old you are and what gender you are, it also predicts your systolic blood pressure within 11 millimeter mercury and also give you a risk for heart attack. I'm thinking that retinal images is not something we routinely think about, but now you can really get point of care, bedside or home-based, that will become something we add in our, maybe not in ICU, but preoperative, because I work in surgical ICU, I think about preoperative, like toolbox of images that we can use really to assess your physiologic reserve or your biological age. And I think this is something to kind of start thinking about, maybe bringing into our research. So that's all I have, and I am on time, so thank you.
Azra, a fascinating talk and really covered all the bases, I think. Questions from the audience, first of all. So I've got quite bright lights in my eyes, if you see any hands come up. If not, while people are getting themselves warmed up to ask questions, perhaps I could... Well, Ellie, you go.
Thank you very much. That was really, really interesting. We are moving from a continuum between artifacts and we are questioning ourselves about the relevance to super relevant data. And on one hand, we need maybe to understand how we can teach these approach to better estimate the artifacts and inform the clinicians. And on the other hand, we need to consider redoing guidelines and rethinking the way we are guiding clinical practice. Can you just help us for the two extremes?
So how, as applied to imaging? I think we need to reimagine a lot of our processes. And, at least I'm going to speak about ICU in America. It's a big enterprise. A lot of things that you've seen here is right now delegated in a low-level staff, house staff, like interns, PA, who read x-rays overnight and miss sometimes EDTU placement, collapsed lungs. It happened to me. So some of these very routine tasks that should be no miss, ever zero miss, need to become zero misses. We cannot have misses, because we have now imaging that can support us. I call this superpowers. Humans don't have a supervision, but now we have tools that give us supervision. So we need to use those tools to our advantage, and that's how I see them. I really look forward to industry really collaborating with us, especially industry that works on the devices in ICU, how these models can be better, more precise, more comprehensive, and how we can together really reimagine the ICU of the future. Thank you.
Anything from the audience? Otherwise, I will ask. Again, while people are getting warmed up. Azra says, thank you. My quick question really about, do you think this is incremental benefits, or do you think this is, a revolution that we can harness somehow? Because I sometimes wonder, so in the neuro domain, spotting a big bleed or something is actually not very difficult. The neuroradiologists benefit from other things like really boring stuff like counting MS plaques, which changes your treatment enormously, but is a really tedious thing to do. And I just wonder where this technology sits, because anyone can spot a pneumothorax, but I don't know. I just wonder what your thoughts are.
I think that's a great question, and I think this is the beginning. Really using this technology for routine, easy tasks to improve efficiency, optimize how we deliver care. But I think the next step really needs to go and ask ourselves: deep in these pixels, there is more knowledge. That's where the research is going to go. Like when you start thinking about if you bring pathology and kidney, I'm talking about kidney always, and see how does what on ultrasound this pathology look like. This is where you're going to start seeing, these images will be source of new knowledge, and I'm really excited about that. I think there is enormous potential for us to surveil our own health and wellness with the multiple images through the lifespan and understand how we age on every organ on a very different scale. We were never able to look so deep or longitudinal. So yes, I'm exciting both. I would say answer is both. Thank you, Ari.
Thank you, Azra. Thank you.
Thank you very much. And now we are moving to the next presentation. I'm delighted to introduce Rinaldo Bellomo. It's not about the Control F, but the new Control F, which is the new generation of natural language processing. Thank you very much, Rinaldo.
Thank you very much for the kind introduction. First of all, to make you aware of natural language processes, a kind of computer science that uses artificial intelligence and machine learning to look at words. It's a component of the new technology that you deal with every day. Maybe you're not aware about it, but you're speaking to Siri, and this is natural language processing. So it's a very common component of your life. It can also be used to look at texts, and you can use natural language processing to mine large amounts of information. You can look at specific words, and you already do that with your computers, or you can even use it to assess the sentiment and the feelings behind paragraphs and sentences. In healthcare, this is now beginning to be applied, and it can be used to look at large bodies of information, to investigate words, to describe patients and situations, opinions and facts that were not amenable to analysis in the past, because until now we've just been able to use numbers. And why should we worry about text and words? Because there are some situations where numbers just don't do it. And one of these situations is delirium. There is no number that can tell you that somebody does or does not have delirium. There isn't an ECG, a chest X-ray, or an imaging that can tell you that there is delirium. The way we deal with it is words, because we have to use a theory of mind in order to decide that somebody is delirious. And we use words like the patient is agitated, confused, disorientated, combative. And that allows us to use natural language processing to try and understand how these words might be applied to the diagnosis of and the monitoring of delirium. And first of all, you've got to ask clinicians, what kind of words would you use to describe somebody you think might be delirious? And you try to develop a library of delirium-suggestive words. And you ask people to classify specific words using a Likert scale to tell you which ones are most likely to be used by them to describe the presence of delirium. And you can see that there isn't 100% agreement, but some words keep on coming up with very high Likert scale values, like confused, confusion, delirious, of course, agitated, agitation, disorganized thinking, disorientation. So you can create a library that you can use to refer to, and then use those words in your NLP analytics. And you can look at how words such as these might have changed over time. And this is analysis of our ICU done by Marcus Young, who's doing a PhD with us. And you can see that the words are pretty constant. They're very common. And for some reason, confused and agitated are the dominant words in our nursing notes. And it might be different in different cultures, but that's what gets their attention. And of course, it makes a lot of sense at a clinical coalface. So we decided to look at what natural language processing could do for us in terms of identifying patients with these conditions. We didn't want to use the word delirium. We wanted to describe the phenomenon as a behavioral disturbance. And the reason we wanted to do that is that saying somebody's delirious has got some implications about the fact that we understand what's going on in their head. And that we cannot do. And it's a false idea. We can only know what they do as it manifests itself as their behavior. And so we looked at a group of about 2,000 patients, and we're able to divide them according to the presence of CAM-ICU positivity and natural language processing diagnosed behavioral disturbance. And you can see there is a degree of coherence between the two, but also you can see that there is some disconnect between the two technologies of delirium screening. And you can see that compared to CAM-ICU, natural language processing identifies more patients that are likely to have delirium, or whatever delirium is, because we can't understand what that is. And it appears to be a more sensitive tool. And it shouldn't be a surprise to you, because the natural language processing of the nursing notes captures all of the nurse's thoughts during a shift, rather than doing a CAM-ICU assessment at a particular moment in time and believing that that is an accurate representation of 8 hours of human behavior. And these patients are sicker, as identified by natural language processing, consistent with a population that is more likely to be at risk of delirium. And you can see then that you can relate that to the use of antipsychotic medications like quetiapine or olanzapine or dexmedetomidine. And you can see that if you are positive for natural language processing diagnosed behavioral disturbance, you're much more likely to get treated with antipsychotic medications. And that is what is clinically relevant. It's telling us that this kind of diagnostic technology is superior to other technologies that we use with screening characteristics. And that is not a surprise. You can then use natural language processing to differentiate subsyndromes of natural language processing diagnosed behavioral disturbance, or delirium, if that's what you want to think about it. Those that have got an aggressive, agitated, combative characteristic, and those that are disorientated, confused, but not agitated. And you can use that to divide patients with agitated behavior versus non-agitated behavior, because this is what really matters at the coalface. And you can do word clouds, and you can see what kind of words dominate when people try to describe agitated behavior. So agitated, agitation, but you can see aggressive, restrained, aggression, combative. You can see these are words that describe a particular phenotype that is very different from this phenotype, which is disorientated, confused, fluctuated, confusion, disorganized. These are two different types of patients with very different kind of activities, very different risks, and very different requirements for management. And you can see, by using this technology, you can assess when these behaviors happen, how many have got hypoactive delirium, hyperactive delirium, mixed delirium at different moments in time. And you can also demonstrate with these kinds of diagrams the movement of patients. They don't belong to one category or another, they move across at different times, different circumstances, and they manifest the characteristics of cognitive neurodysfunction in different behavioral patterns. And so, again, patients with agitation are more likely to get antipsychotic medications because to the clinicians, the nurses and the doctors, what really matters is agitation, because that's problematic, it's dangerous to the staff, and it's dangerous to the patients. More importantly, we do not have any medications to fix hypoactive delirium. If there was one, I want it. So again, you can see the profound difference of agitated versus not agitated in terms of the odds ratio of using antipsychotic medication. But there is more to the world of neurocognitive dysfunction that can be identified by natural language processing. And one of the things that we've never really been able to study properly is the occurrence of hallucinations. Hallucinations are false perceptions of objects or events involving your senses. They seem real, but they're not. And they're typically present in schizophrenia, but they're also present in our patients in the ICU, but we've never been able to study them. And again, Marcus Young has focused on this, and there'll be some posters downstairs if you want to go and look at that. And we studied hallucinations in the ICU. And you can see the hallucinations are recorded by nurses, doctors, and physiotherapists as reported by patients in about 8% of patients in the ICU. And again, the world of hallucinations is very similar to the world of delirium, with transitions over time of patients from a state of neurocognitive stability to a state of hallucination, in and out, and that is not a surprise. This is a frequency plot showing when hallucinations happen and the frequency of such hallucinations. And you can see that hallucinations and delirium on natural language processing overlap with each other, so that they appear to represent two different states of neurocognitive dysfunction which have got a relationship which we do not yet understand. And then once you've got all of that, you can make these diagnoses and these assessments and look at the flow of changes over time. You can see if there are associated factors for them that you may not have been able to perceive in the past. A reasonable question is, does the use of low-dose ketamine for pain control associate with hallucinations? And you can look at the characteristics of patients receiving ketamine, the dose of ketamine, the mean daily dose of ketamine. This is a low dose, 0.1 milligrams per kilogram per hour. There is no data in the literature as to whether this increases the risk of hallucinations in ICU patients, but it does. And when you look at the use of ketamine versus the patients that did not receive ketamine, you can see there is a dramatic difference in the incidence of hallucinations in those receiving low-dose ketamine. And indeed, the use of low-dose ketamine in ICU increases your odds ratio of developing hallucinations 6 times. Now, this is something that's just not been perceived, not been published, not understood, and it gives you a quantitative assessment of what that can do. And we know the hallucinations that are associated with delirium. What does low-dose ketamine on that? We're going to be studying that very soon. And so natural language processing is part of a large revolution. You've seen the imaging just before me that will transform the way we use not only imaging, but words, text. And there isn't going to be a long time before all of us will have a microphone and will be dictating all of our thoughts, our components, and our assessments into a text that can be read real time and used to assess sentiment, prognosis, impressions, family discussions, and so on. Of course, the world of psychiatry is ready for it, and it will be investigated by this kind of technology. So let me conclude by saying that natural language processing is a novel investigational tool in intensive care. You can read millions of notes overnight. This information allows the large-scale investigation of conditions that are not easily defined by numbers and are typically defined by words. Such conditions include delirium, behavioral disturbances, delirium phenotypes, hallucinations, and other mental states. The study of the epidemiology can shed light on risk factors, as I've just shown you for ketamine, And this is important because it gives clinicians a better understanding of the consequences of their therapeutic actions. So NLP has a real potential to provide further insights in other aspects of patient management in ICU and is rapidly evolving, or at least that's what the chatbot is telling me. Thank you very much.
Thank you very much, Rinaldo, very enlightening. We have time for questions and comments, feedback, or maybe shared experience. Yes, please, if you can get close to a mic. You can also come here. Come here. Come here.
Hello again, it's Dr. Azra. Thank you for this good presentation. And I want to ask you something about that. Use ketamine only that or some drugs add them?
So we use ketamine for
intensive care unit, you use only ketamine for sedation or?
pain relief. Ketamine as an adjunct analgesic in patients where narcotics alone are unable to achieve the desired pain control, and where there is a perception that additional narcotics are potentially dangerous, and therefore we move on to use low-dose ketamine.
Okay, thank you very much.
Thank you. We have time for another question. Yes, please, Ari.
Yeah, thanks, Rinaldo. So you nicely demonstrate that you can get a phenotype, a behavioural phenotype out of text, essentially, which is really nice. I suppose my question really is, to what extent do you think that this phenotype actually represents a biological endotype? Because that's what we want to try and treat. And if it doesn't, then there's a danger that what we're actually measuring is a phenotype that is partly determined by the cultural behaviour of the nursing staff and potentially socially determined by the cultural behaviour of the patient. I just wonder what you think.
Look, I'm sure there is two components, but the nurses are looking at the patients, and I don't think the nurse would just write agitated, combative, and aggressive unless she was being punched or kicked. And I think whether this reflects a different biotype underneath is a big question. And geez, before we can understand that will be a long time. But I think it's fair to say that those patients that are agitated and combative are more likely to be boys, and they're more likely to be young boys. And that's consistent with the biotype to a degree, right?
Yep, certainly fits.
Rinaldo, if I may, a small question about responsiveness of NLP. Because you have been using it not only to detect a rate of event at the T time, but also over time with repeated data. And the other thing is that you are also able to capture outcome variables. So then you increase the sensitivity and the rate of event in a given population. How do you see that compared to the classic way we are collecting data?
I think it's very powerful because the data we're currently collecting on all of the interactions between staff and patient is absent. We just don't have any of that. We just look at the sodium and the potassium and the chest x-ray, but this interaction between the patient and the nurse and the patient, the physiotherapists, the doctors is totally uncaptured. There's a lot of information there that allows us to understand what goes on. I mean, this is just the beginning of looking at text. Just imagine a psychiatrist with their client and their conversation and we're going to have face recognition, we're going to have sentiment analysis, we're going to see what the patient's face is showing, we're going to see the psychiatrist's face. I mean, this is going to be a revolution of our understanding of human interaction in a way that has not been possible before because it's quantifiable.
On a really practical note, one of the things that drives me slightly insane on a daily basis is the amount of cutting and pasting in notes, though. Any thoughts about that? I mean, do you take that into account, or do you create your notes to remove the?
So this requires obviously some technology, removing the negatives like absent, not, no, and sort of stuff. The people misspell, so you've got to have stem of the word assessment, and people do cut and paste, but mostly it's numbers that they cut and paste, and it's not that much cutting and pasting of somebody else's opinions or comments. Yeah.
We still have time for one question if some of you have a comment or a feedback. If not,
thank you very much.
Pleasure.
Okay, well, in that case, we'll move on to our next speaker, Matthieu Komorowski from Imperial London. And Matthieu will be talking to us about implementing machine learning into actual clinical practice. Matthieu.
Thank you, Ari. Thanks, everyone, and thanks for having me. Yes, so let's talk about integration of AI into clinical practice. These are my conflicts of interest. Well, the first thing to say is that we don't integrate. And here is a picture that summarizes the state of the field. This is 4 years old, but the message is still very much the same. This is a survey of about 500 AI in the ICU papers and models. And what you see, the x-axis is years, right? The y-axis is the level of technological development and readiness. And the bulk of the literature is at the phase of early model prototyping and very early model development, and very few prospective validation, deployment in the clinical setting, assessment of a validated medical device. All right, so I could stop here, but I think we should dive into a little bit of detail. So what I suggest we do is we're going to look at a few examples that I cherry-picked from the literature that will allow us to illustrate the purpose of how AI is integrated or isn't integrated. Okay, I suggest that these papers can be sorted in 5 categories: few success stories, what's I think are promising applications, maybe we'll get there, will be integrated at scale eventually. What can we learn from all those models that turn out to be very difficult to integrate? A few horror stories, and there's a lot of useless research out there, let's be honest. All right, let's start with success stories. We can turn to the FDA to look at what they've approved for clinical use. You know, maybe that's one lens through which we can try to understand this area. The latest list published by the FDA in August of last year has 950 devices that are AI-powered. 950. It's big, we're getting to significant levels. And when we look at what specialties are most represented, well, radiology is 75% of that. And Azra talked about it very accurately. Then you have cardiology and so on. The other specialties are actually quite minor. One example, Azra told us about Viz.ai. They were actually the first one to get FDA approval, I think, back in 2017. And I'm not going to repeat what Azra said, but they have a number of studies. This one is the latest one they have, where they show that deploying their system shortens the time between hospital admission and arterial puncture for patients with ischemic strokes, right? For this process of thromboaspiration by about half an hour. So whether that correlates into clinical outcomes, they don't report that, but it's an interesting signal. How about AI for STEMI diagnosis? It sounds like a very straightforward application, right? This is, to my knowledge, one of the only randomized trials that's ever been done. A very nice paper. It's actually just an abstract at a conference, surprisingly, done in Taiwan, I believe. There's a phone here that's ringing. Oliver. Okay. Shall I pick up? So 40,000 patients included into this randomized trial of an AI system for STEMI diagnosis. The primary outcome is very interesting, clinically relevant. Do you want the phone? The primary outcome is a time from ECG to cath lab, and again, a reduction in about 10 minutes. That's potentially interesting, significant. We're in 2025, of course, we have to talk about LLMs and ChatGPT. I wrote this editorial 2 years ago about what potential uses we could have of these tools. I'm going to highlight one, ambient scribes. I don't know if any of you has this available in their hospital. This is a cool report of experience of deploying an AI scribe in a large hospital system in California, KP, Kaiser Permanente, where they made it available to their 6,000 doctors. About 3,500 of them decided to use it, and you see over a couple of weeks, the AI generated over 300,000 summaries of the interaction between clinicians and their patients. And the feedback was good, the summaries were accurate. If you use those in your meetings, you know how good they are, and it's not surprising that this is, in my opinion, a very exciting application of this technology to reduce the burden of documentation, to improve the accuracy of notes, and then we can actually do research like Bellomo was presenting on those notes, right? So success stories, what can we learn from these? All right, what does it say about the field of AI in healthcare? I think there's a few things we can isolate from these papers. Well, they all address something that is clinically useful. That's a good place to start. They all rely on some AI that is mature at the time of being integrated into those tools. Radiology is so prominent by the FDA because of convolutional neural networks. These technologies have been around for at least 20 years in the current form that is integrated into those models. So way before generative AI. The validation of those tools is rather straightforward, right? You have a gold standard. You know what the true labels are when you train an AI to predict whether a chest X-ray has a pneumothorax or pleural effusion. You have a ground truth. That's not necessarily the case in other applications, as we'll see. Lowish risk, right? Handling medical notes, writing discharge summaries. It's not quite the same risk as an AI that would drive an infusion pump running noradrenaline into a patient, right? We have large data sets available for these applications, and interestingly, there's usually no need for multimodal data. To train an AI model in radiology, you need radiology images, right? You don't need to combine vital signs, lab values, infusion pumps, all the treatments, from multiple sources. So that's something else that's important to note. And then there's usually less issues of scalability. You can work with a provider of software in radiology and integrate with them, and then you have access instantly to hundreds of or thousands of hospitals. You don't have to manually plug it into the EHR system, for example. And for many of these applications, there is a business model. It's a technology meeting a business. Promising applications here. I think I'm just going to talk about two: triaging in ED and sepsis prediction. ED triaging. This is a paper from last month, New England AI, a pre-post design. So before deploying an AI and after, the input data into this AI model is everything you would expect at the time of ED admission, and then the study is. Asked the nurses, the triage nurse, to rate, to rank, to classify patients on a scale of 1 to 5, which they call the emergency severity index. 1 being they're very sick, they need to go straight to ICU. 5 meaning they're not sick, they can probably go home. Okay, and then this is the interface where after they deploy the AI, you get a suggestion from the AI triage clinician decision support system. And then at the bottom of the page, the nurse has to agree or disagree and give their own assessment of the acuity of the patient. What they found is interesting. They found that patients were reclassified after the AI was deployed. More patients were classified as low severity, and less patients were classified as high severity. They also report a number of time outcomes that are interesting: shorter time to initial care in ED. Shorter time in ED, quicker discharge. And interestingly, the patients with the highest acuity spent on average 2 hours less waiting to go to ICU. So interesting signal. It remains to be seen whether this translates into improved clinical outcomes, but I think it is an interesting paper and a large cohort. Sepsis prediction model, this one you've probably seen. It's nearly 3 years old now, but it's a large prospective trial that was not randomized, where an AI sepsis alert had to be confirmed by healthcare providers in order that was used as the criteria to dichotomize the patients into 2 groups. So it's not randomized, but nevertheless, the signal is interesting: less mortality, better SOFA progression, shorter length of stay. Another sepsis prediction model, more recent, from last year. A before and after study, another one of those. So it's not randomized, but it's still a very relevant design, I would say. They deployed a sepsis prediction model, 6,000 patients with sepsis, and what you see is, so the red line on those plots is the intervention time, the time of deployment of the AI. You see that the hospital sepsis mortality decreased, and SOFA progression is more favorable after the sepsis prediction alert is deployed. They report 1.9% decrease of in hospital sepsis-related mortality. What about those models that prove to be very difficult to validate, even to train, to deploy, to integrate? There's a few things we can learn from looking at the literature. Well, some models are just plain hard to train because we face a problem of what we can call partial observability. We don't have all the required data in the data set to train those models. Think about the extubation failure prediction. Right? There's so many other factors that come into the fact that a patient is going to fail extubation. Maybe their cough is a bit weak. Maybe they have a lot of secretions. Maybe they're drowsy, but their GCS is above 8, so they still get extubated. Maybe they have a stridor when you extubate. All of that is not captured in numerical data, so it makes it really hard to train a model that will learn this mathematical relationship between the patient's input data and extubation failure. As I mentioned before, if you have an AI that requires live multimodal data, that's hard. Some systems actually increase the workload. It makes it really hard for healthcare professionals to use, to accept, to adopt. It could be difficult to validate. If you think about reinforcement learning, you end up with a strategy that is different from what the doctors did, and now you have to decide whether you're confident enough to test it on patients. Really hard. Maybe the application is high risk. I was thinking about hemodynamic management. Maybe the regulatory pathway is very unclear. The FDA, the MHRA in the UK are working alongside academics to update the regulations along the way. And maybe there's no business model. So unfortunately, I think that's potentially a lot of potentially useful AI applications that fall into this category. I have two what I call horror stories in a bit of a dramatic way, but you see what I mean. You can rely on the technology acceptance model to try to make it a bit more objective what you're trying to optimize when you want a new technology to be adopted. And what it says is that you have to improve the ease of use and the perceived usefulness of this technology. All right, so let's look at one example which has been widely cited, but I think it's an important paper. An AKI alert generated in the EMR. So there's no AI. The patient actually has an AKI, and then patients were randomized into receiving, the doctors would receive the alert or not. It looked like this. Your patient has been identified as having an AKI. You can order some treatments. Look at their drug prescription chart. Okay, so perceived ease of use, yes. Usefulness, yes. What this framework ignores is that at the end of the pipeline there's a patient. Right? And actually what happened in this trial is that in non-teaching hospitals, so this is orange on the plot, you see that the mortality actually nearly doubled without a clear explanation. Very, very frightening, and this raises a lot of questions. Another, maybe not a horror story, but something that's concerning is that you can measure the heterogeneity of the effect of an AI on the healthcare professionals. Here in radiology, what this paper shows is that for some doctors, sometimes the AI makes your performance worse. It increases your error rate. Some doctors, not all of them. And also there was no association between years of experience, subspecialty, familiarity with AI, and the effect of AI. Conclusions, I think what I would say is that building a machine learning model is rather straightforward, especially these days. Designing a human AI system is not straightforward. In this aspect, multidisciplinary work is really crucial, and that's a picture of my team at Imperial in London, and you see that it's highly, highly multidisciplinary. You have machine learning experts, clinicians. We work very closely with the hospital informatics team, health economics, medical device development, human factors, right? That's the kind of multidisciplinary that you need. Generalizability versus local recalibration, that's a difficult technical question. What evidence will be required from users and from regulators? I would say that randomized trial is probably what we need, right? And more randomized trials, comparing standard of care to AI. It's a good idea to follow, this is what we're doing in London, we follow this pipeline of sequential studies that become more and more dangerous and more where you increase the fidelity of the setting. Okay, 2 more questions. How can you integrate at scale? And what is the business model, right? Who will pay for this? And can you make it, actually, can you balance the cost of deploying those tools? Thank you.
Matthieu, thank you for a tour de force of exploration of the landscape. Any questions from the audience? I'm shielding my eyes. If not, maybe I will start. I was really taken by the slide you had on some of the reasons that some of the things that have been deployed, right? So, and some of the things that really struck my eye was there was a clear use case and a clear route to market and business model. And I suppose my question really is what we want to achieve is proper stepwise change to healthcare. But that's not normally a use case. Normally a use case is I struggle with doing X, Y, or Z. And sometimes I struggle with doing X, Y, or Z because in fact X, Y, or Z is something I shouldn't be bothering to do in the first place. So actually I need to redesign the whole system. But bringing something in that's expensive just to help me do something that's a bit pointless maybe isn't, I mean, it may be good for me. It may reduce my burnout. It may increase staff retention. It's not bad, but it may not bring the stepwise change that we want. Do you think that those constraints, I think you could think about that you put on that slide, are a fundamental problem for this technology in terms of moving forward? You know, are we just going to evolve, or are we going to really, jump?
Right. So you're asking whether the business model and the financial aspects are something that's important for us to consider as academics.
Yeah, but will those constraints mean that we'll never see things that are truly revolutionary and change our hospitals getting in because it's just too complicated?
Yeah, that's a difficult question, right? Whether what's going to happen is incremental changes, as you described it, as many of those technologies actually do, right? We're not talking about reinventing medicine, which is maybe what we should be working on. So maybe as intermediate steps, many of those applications can start being deployed and used. The revolution. I'm not sure. What do you think?
I don't know. It's sort of philosophical, isn't it? I think about the urgency, and I think about the massive sort of tidal wave of chronic ill health that we are seeing in the very near future, just from demographics. And I see healthcare services that are largely on their knees, and I see that technology might be a way of getting out of this. But what I don't see is I suppose, Jeff Bezos, I don't know actually, but I don't know his backstory, but I imagine he wasn't selling books out of a back room with a little lorry and then got a computer and suddenly Amazon was born. I guess Jeff Bezos saw computers and thought, here is an opportunity for a completely new way of doing things, and I wonder whether we need to do that in medicine. Is a technology completely new way for us to work as well? I don't know.
And have a 20-year vision and many billions of investment?
Well, that would be nice. Thank you, Matthieu. If there are no more questions, thank you.
Thank you.
Thank you very much, Matthieu. We are now moving to the next presentation on algorithm-driven hemodynamic management with Frederic Michard. Thank you, Fred.
Thank you very much. Hello, everyone. Thank you, Jean-Louis and Fabio, for the invitation. So I'm going to talk about AI for hemodynamic assessment. Before, I'd like to disclose the fact I'm today leading a consulting and research company based in Switzerland, and where we focus on digital innovations with medical applications. So I'm going to talk about blood pressure monitoring, the prediction of hypertension, hemodynamic profiling, and point-of-care ultrasound evaluations using AI or machine learning algorithm. So the good news is that regarding blood pressure monitoring, soon it will be possible to monitor blood pressure continuously from a pulse oximetry waveform. The concept is pretty simple. You have a machine learning system. You're going to feed with a large number of pulse oximetry waveforms. And you will give, during the development phase as well, blood pressure values, because you will monitor continuously blood pressure during this phase. Then the algorithm will learn to recognize specific patterns associated with a drop in blood pressure or associated with a low blood pressure, or in contrast, specific patterns associated with a rise in blood pressure or high blood pressure values. So here's an example of an existing algorithm developed by the CISM in Switzerland. And you see that over this 10 minutes period, so there is an initial calibration with a brachial cuff, but you see during the next following 10 minutes, the algorithm, actually using the pulse oximetry waveform, was able to follow pretty accurately changes in systolic pressure, mean pressure, and diastolic pressure. So this algorithm was actually used already in this clinical study published a few years ago, where they tracked changes in systolic arterial pressure on the left-hand side or changes in mean arterial pressure on the right-hand side during anesthesia induction. And you see it worked pretty well. So the concept we see coming probably pretty soon is the following. We will continue to use brachial cuff, oscillometric brachial cuff, to measure blood pressure from time to time. But between these intermittent measurements, we will get information regarding blood pressure continuously. And in case of deviation detected or suspected by the algorithm, it will trigger automatically a new blood pressure measurement with the brachial cuff that will enable to confirm that there is indeed a rise or a drop in blood pressure, but also to recalibrate the algorithm. The prediction of hypertension. Here we are going to try to predict, to forecast what's going to happen in a few minutes or a few hours. You may have heard about this commercially available HPI hypertension prediction index. The concept is a bit the same. I mean, a machine learning algorithm was used to predict hypertension so the algorithm was fed by a large number of arterial pressure waveforms, and the algorithm was able to recognize specific patterns associated with a subsequent drop in blood pressure. So this is the very first study, validation and development study, suggesting a very good predictive value. You see the area under the ROC curve above 0.9 to predict hypertension, to forecast hypertension 5 minutes, 10 minutes, or 15 minutes ahead. We know now that actually some of these initial validation studies overestimated the predictive value. For methodological reasons, I'm not going to dive in. I don't have the expertise. But if you are interested, be aware that these two Danish guys published a lot on what they call data leakage. The bottom line for clinicians is that the positive predictive value is quite low, around 30%. These are two recent papers published last year in anesthesiology, and the second one is actually published by the developers of HPI. When you have a positive predictive value around 30%, it means that 7 out of 10 hypertensive alerts are false. So if we have a low positive predictive value, we risk to administer treatment that is not justified. For example, we may give vasopressors to patients who have a high HPI value but are normotensive and would never become hypertensive. So this is also an interesting paper. I think if you had just one paper to read on the topic, I would recommend that one because I think it's very well balanced, discussing the potential value but also the limitation. It was published last year by Mukamala. He tried to assess the benefit-risk ratio of using HPI. And he concluded that the probability of unnecessary treatment is around 10 times higher than the probability of preventing organ injury. What we need to know as well, or what you need to realize, is that the mean arterial pressure itself has actually the same predictive value as HPI. It becomes obvious when you look at the relationship between HPI and MAP. It's not linear, but it's very tight. And so in practice, what does it mean? It means HPI is more or less a reflection of the MAP. And so it seems the algorithm learned that when the MAP is low, the probability it becomes very low is higher than when the MAP is high. That's kind of common sense, right? But we should not forget that machines will also learn what we already know. In practice, what does it mean? It means that as soon as the MAP is around 70, actually to be precise, 72, most of the time, HPI is above 85. And there are now at least 4 large studies confirming that the predictive value of HPI and the predictive value of the MAP are exactly the same. Here you see the area under the ROC curve to predict hypertension 5 minutes ahead or to predict hypertension 15 minutes ahead. So the limitation of the HPI itself, alongside the hemodynamic protocol it triggered, we could discuss as well, but we don't have time, may have contributed to the lack of improvement in outcomes in this study published just a few weeks ago. That was the very first study powered to assess the potential impact of HPI on postoperative outcome, and they failed to show any improvement. So how can we or could we explain these results? Maybe some patients did benefit from a proactive strategy. As soon as HPI was above 85, which means in practice, as soon as MAP is below 72, you are proactive, you start treating, you give fluid or vasopressor, and of course you prevent hypotension. And we may imagine some beneficial effect for some patients. But on the other hand, we have all other patients because of this high rate of false positive alerts who may receive unjustified treatment with associated side effects. So maybe at the end, we have a kind of balance explaining that in this study, they did not report any benefits, but they also did not report any harmful effect associated with the use of HPI. Hemodynamic profiling now. So many of you in the room from my generation learn cardiovascular physiology using these kind of tables. These tables describing hemodynamic variables we can measure with a Swan-Ganz catheter, and we can then from there describe the different hemodynamic phenotypes or profiles. We can do the same using pulse wave analysis techniques, which, as you know, are increasingly used. And here, typically, it's for systemic hypertension. So all these examples, all these patients develop systemic hypertension, some because of vasodilation, some because of low cardiac output. And then the cardiac output may be low because of bradycardia. It may be low because the stroke volume is low. And then, in this case, if the patient is fluid responsive, it looks like a hypovolemic state. Or the blood pressure may be low because the cardiac index and the stroke volume index are low, but the patient is not fluid responsive, so it should suggest cardiac dysfunction, and I guess you'll jump on the echo machine. So these are the four main phenotypes or profiles associated with systemic hypertension. Recently, it has been proposed to use AI to identify hemodynamic phenotypes associated with hypertension. So, of course, it's technically doable. I mean, you can develop a machine learning algorithm and report or describe these four different clusters, which are, similar to what we describe with my very old table: vasodilation, bradycardia, myocardial depression, and hypovolemia. But finally, at the end, we have again the feeling that AI tells us what we already know, and finally, what medical students learn from textbooks. So I know what some of you are going to say. Yes, but we make mistakes. We make mistakes all the time. Yeah, it's not untrue. But computers make mistakes as well. And in this study, actually, if you look carefully at the results, you realize that some patients who were classified bradycardia had a heart rate above 60. And I don't know a single clinician in the room who would give atropine to increase heart rate when it's 65. The algorithm made mistakes also for the identification of vasodilation. As you can see, although the median SVRI value is below 1500, and there are obviously patients who had the SVRI value above 2000 or even above 2500. So computers make mistakes as well. So in addition, we have already tools to quickly, easily identify hemodynamic profile. I mean, this is just the example of a screen you may find on modern hemodynamic monitors. Visually, you realize it's a hypertension related with or to vasodilation. Here, it's hypertension related to low cardiac output because of bradycardia. Here, you have hypertension related to a decrease in stroke volume index in a fluid responder patient, so it's typically, obviously, a hypovolemic state. Here you have the same kind of profile with a low blood pressure, a low cardiac output, a low stroke volume, but the patient is not fluid responsive, so it's probably coming from the heart. That's very basic, right? And that's even visual now with modern screens. We have a visual signature, a visual pattern, and we don't need a computer to identify this pattern. It's hemodynamic profiling at a glance. So AI for big data, yes, definitely, but to analyze 4 or 5 hemodynamic variables, I'm not convinced this is necessary. I will finish with POCUS evaluation. So first of all, ultrasound devices dramatically evolved over time, and that's basically what I was using as a resident. I had even to borrow the machine from the cardiology department because we did not have any echo machine at that time in the ICU. And on the right-hand side, I mean, that's what many residents today have in their pocket, a mobile wireless probe they can connect to a smartphone or to a tablet. There are many different products on the market. They all have advantages and limitations, but what's key is that more and more they have AI on board. AI to help correctly position the probe on the thorax. AI to confirm you have a good quality image, and then you can rely on your measurements. AI to automatically label health earth structure. AI to help you measure key variables using echo. So you know VTI, the subaortic VTI, is frequently used as a surrogate for stroke volume. And it can be automatically measured by a machine learning algorithm. So this is how it works. You see a 5-chamber apical view. The algorithm will recognize the left ventricular outflow tract, will position automatically the caliper in the tract, and then will inform you with this green trapezoid that it's a good quality image, and then you can rely on the measurements, and it will automatically average VTI over 4 seconds. So we tested with Philippe Gonzalez, with I think in the room, this algorithm a few years ago against measurements done manually by an expert, and showed pretty good results, in particular for trainees. You see the percentage error was 26%. I remind you that for cardiac output, we accept cardiac output when the percentage error is below 30%. Here is another algorithm measuring automatically and continuously left ventricular ejection fraction, again using color coding, telling you if it's good or bad quality images. You see here an example with a continuous LVF, normal LVF. Here another example, a low LVF. You don't even need to take the measurements yourself anymore. With Philippe, again, we tested against manual measurements done by the expert, and again reported a very good agreement between measurements done with the algorithm and measurements done by the expert manually. And what was interesting in this study is that the reproducibility of LVF measurements was better for novices using the machine learning algorithm than for experts taking manual measurements. So that's probably one of the main advantages of these techniques, particularly in the field of imaging. It's to improve the reproducibility of evaluations. So in conclusion, AI is not the ultimate solution for everything, in particular for hemodynamic assessment. If we just briefly review what I discussed, it should be possible very soon to monitor blood pressure continuously from a pulse oximetry waveform thanks to AI, but it's not yet commercially available. HPI is commercially available, but it does not predict hypertension better than the MAP, and the high rate of false positive is associated with the risk of unjustified treatment. Hemodynamic profiling, as far as I know, is not commercially available, and when it will become, I think we will question the superiority of our existing tools, basic tables from a medical textbook, or even the screens, the decision support tools, the visual decision support tools I shared with you. And last but not least, ultrasound devices may help us to get optimal imaging, particularly useful for novices, I believe, and may automate the measurements of several variables. So once again, and that will be my last comment, it seems that it's more for imaging techniques that we can expect a lot from AI, at least on a near-term basis. With that, I thank you very much for your attention.
Thank you very much, Frederic. We have time to open discussion on this very challenging topic. Please, if you can get close to a mic, we would have you better. And you are welcome. Oh, you have a mic here. Thank you very much.
Thank you for the presentation. For analyzing the prediction of hypotension, did you consider using not only blood pressure but also perhaps heart rate variability in the short term? I mean, that's a value or a metric that you can use within seconds or within minutes and might add sensitivity or specificity for the So
measure. You mean using heart rate variability to predict hypertension in addition to other... I don't know. I don't have in mind any publication on the topic. I know there are many studies using heart rate variability to try to predict this and that, but not specifically hypertension, from what I know. Maybe you should try.
Yeah, I will try.
Thank you very much. Another question or comment?
Maybe I can make it.
Yes, please. You can. Oh, you have a mic just here. Thank you very much.
Thank you so much. Great presentation. So my question would be, so we saw a lot of great applications that are on the edge. You know, it's not centralized. You can deploy them anywhere. You can deploy them on a low-level trained staff. So why then having ICU? Why wouldn't any hospital in bed be ICU? If you can deploy ultrasound, you can deploy remote monitoring, you can put everyone in the same intensity of monitoring. Why do we need geographic ICU, in your opinion? Like, why do we need to sequestrate them?
I'm not sure I got your question. What do you mean?
So I mean that, like, with technology today, every room in hospital can become ICU room. We can deploy the same intensity of monitoring everywhere. I can have ultrasound everywhere. I can monitor hemodynamic everywhere. Why being in 8 beds or 24 beds?
Okay, I like dreams, but I think we are not there yet. And I'll give you a scoop. We just did a big survey in middle-income countries, and it seems that only 1/3 of intensivists working in middle-income countries have access to existing technologies. So I think it will take time before these kind of super exciting innovations reach all of us, particularly middle-income countries.
Frederic, can I ask a question? I mean, you show very nicely that the HPI was very correlated essentially with, it's a mirror image of MAP. And to be clear, I'm not saying anything was wrong here, but what we've ended up there is a slightly salutary story that maybe innovation has ended up was actually marketing, or, in the end. And I just wonder, any thoughts for the audience about how we make sure that we don't end up in that situation in the future? Because there'll be more and more products that come along, some of which will be good and some of which maybe may turn out to be a bit like the HPI.
I think what's really important is what we do, is to do clinical studies and then to look realistically at the results and then make the right conclusions and move on.
Maybe be a bit critical about things.
Fred, just one comment on this specific topic of hemodynamic management. We are in a research area and a clinical practice where there is very little agreement, not only on the objective, the targets, and the way we assess hemodynamic management, and we do it on a clinical practice. For example, there are no randomized control trials showing superiority of, I would say, management A over management B if we compare echo versus non-invasive management versus others. So would you use algorithms maybe more to train doctors to what is the evidence and see whether there are clinical outcomes rather than leaving the algorithms suggesting decisions?
Yes, I think that would be wise, by the way, to start small, I would say, and to start by using these tools more for training and education and better understanding the different phenotypes before, of course, the following step which is very exciting, but we have to be super careful, would be actually to drive automatically treatment administration. So, yeah, I concur with what you just said. Yeah.
Thank you very much.
In that case, we'll move straight along, and I had the great pleasure to welcome Paul Elbers from Amsterdam UMC to the stage to talk about the third pillar of machine learning, which is reinforcement learning.
Thank you kindly, Ari and Ili, for that introduction. And I must say it's absolutely phenomenal to be here in Brussels again. Thank you so much, Jean-Louis Vincent and Fabio Taccone, for inviting me back. I am from Amsterdam, where I lead a Center for Critical Care Computational Intelligence. You might know this center for the release of the Amsterdam UMC database. So this is the first freely available European ICU database. And in terms of biases, I work with a scale-up company called PacMat, and also do a little bit of reinforcement learning for Fisher and Paykel. And I'm also, as for academic biases, the current chair of the ESICM Data Science section. So, first of all, today is a very special day, not only because my hometown celebrates its 750th birthday, and not only because Ajax, my favorite soccer team, celebrates today its 125th birthday, but I myself celebrate my 50th birthday. However, we're here to talk about reinforcement learning. It's actually my second love. So I'm really enthusiastic about this type of machine learning, and I hope I can convince you of that. But if not, you can read this primer. And before I dive into that, it's good to know that reinforcement learning really came to the table when it beat the world champion in the game of Go. And this world champion is called Lee Sedol. You see him in the picture here, absolutely devastated. And I want you to remember this. So in the analysis, because there was a famous move, I believe it was move 37, that was basically not human behavior. And so the analyst said, so when AlphaGo plays a slack-looking move, you might regard that as a mistake, right? But perhaps, because it actually led to victory, it should be more viewed as a declaration of that. And I want you to remember this phrase because it is important also for medicine to keep thinking outside of the box. So first of all, machine learning can be grossly divided into 3 categories, and reinforcement learning is a very important one of those. And we're all kind of used to reinforcement learning, especially if you have kids. So I have a 6-year-old son and a 4-year-old, and in the Netherlands we like to bike, right? So my son is trying to learn to ride a bike, and there are some rewards when there's success, but there's also some penalties when he falls down, right? So, but ultimately the reward is better. So now he's a very happy biker. But we can also project this to, for example, the game of chess, and this is a good example to teach you about reinforcement learning. So if we have the chessboard, there's a certain state of the pieces, and we can, as a chess player, we can do a move that is called an action, and then our position may get better. So we can maybe get a tiny reward, right? And then ultimately we might win the game, so we get a very big reward because we win. And then if we play the game again, then we might learn the best strategy. But when I say chess player and chessboard, we can also easily say ICU patient versus intensivist, because I bring to you that artificial intelligence and intensivists, they might be more similar than you think, because I take it to you that intensive care is actually one big sequence modeling problem. Think of everything you do. You make many, many micro decisions every minute, every hour, every day, and then ultimately they lead to some kind of reward, hopefully survival and good quality of health of your patient. And the beauty of this is that reinforcement learning has actionability and causal inference built in because it learns from all the actions sequentially. So some people might worry that this is a black box, but I am not proud enough to say that intensivists are also black boxes, right? So, and basically when we treat a patient, we have similar things, right? So we also get mini rewards because physiological signs get better, and we might get the ultimate reward of having patients survive in good quality of life. So it is very easy to replace the intensivists in your mindset with, for example, an artificial neural network that does this policy for you. So the big problem for reinforcement learning for intensive care medicine, that it is currently considered unethical to bring this into practice. So we're somewhat limited to offline batch reinforcement learning. And the reason is that we are a little bit afraid that recommendations by reinforcement learning might be harmful, because the way these policies are usually regarded is that they need to explore the so-called action space, so the combination of actions it can advise to find the best action. But if that action is not good for the patient you have in front of you, yeah, I mean, it's not like playing an Atari game, right? It can be compared to playing games, but ICU is very real. So let's talk about a few examples to make more clear what I mean. And the most famous example that we've seen this many times before, it is authored by first author Matthieu Komorowski, who was just speaking to you, and he developed one of the most famous reinforcement learning models. Basically, trying to address the problem whether or not to give fluids or vasopressors or both or neither, right? So he basically divided patient states into 750, or to be more precise, 752, because ultimately it could also be alive and dead, 752 states based on clustering of all kinds of parameters from the electronic health record. And then in these famous figures, it was shown that the reinforcement learning algorithm suggested a policy, and if clinicians would retrospectively have adhered to that policy, so if they would have stuck close to that policy, patients would survive more often. And this gave a U-shaped curve when we were looking at vasopressor dosing. So if you would stay close to the recommendation, if you would have stayed close to the recommendations, patients would have done better, and a more linear-shaped curve for intravenous fluids. Now, I have to say that these kind of curves should actually not be used, right? So, because they are fraught with all kinds of biases, and they do not control very well for confounding. So I'm very happy that recently a paper also authored by the same Matthieu Komorowski advised against using these kind of U-curves, right? But it is still very useful to have some kind of grasp of what this technology can do and about all the choices you can make when you're trying to develop and test a reinforcement learning model. Because you first have to define, as I told you, the state space. And this is usually being done by a combination of routinely available parameters from the electronic health records. It can, but the input of that can differ. You can put it in as a vector, so a series of numbers, or you can first do an algorithm of clustering, like Komorowski did. But more recently, there have also been applications of autoencoders or Gaussian processes to have a representation of that space. So it's like a representation of those numbers, make up an image, a mental image for the model of your patient. Now, the second line depicts all the choices you have for your actions. So you can just use a simple grid, for example, a 5x5 grid of combinations of, for example, a lot of vasopressors and a lot of fluids. So you have 25 combinations. But there can also be, there are also models that deal with continuous dosing. Now, in terms of rewards, and that is the way reinforcement learning models are trained, there's usually some kind of terminal reward, like survival. But that is an issue because it will only give you a reward at the very end of a trajectory. So there have been some experiments with trying to put in intermediate rewards, like, for example, improving SOFA scores. In the meantime, almost every type of model architecture has been tried for the ICU. And you see a lot of these, such as the deep dual-link Q networks, but also policy iteration and actor-critic methods. And the real problem for reinforcement learning in intensive care medicine is the evaluation. Because of the current constraints, you cannot do it live. So you need an off-policy evaluation method. So you need to find out what would have happened if you would have followed the model. And techniques like weighted importance sampling or fitted Q evaluation or double robust methods are things that you hear in that space. So it is always very hard to do these talks because this is going so fast, this field, that you need to update them constantly. So let's look at some examples that are already out there. So this has already been used to develop algorithms to optimize steroid therapy, also to personalize renal replacement therapy initiation, optimize ventilator settings, usually trade-off between PEEP, FiO2, sometimes tidal volume. Even further, it has been shown that it is useful to control left ventricular assist devices, or develop a model to optimize dexmedetomidine dosing to prevent, well, if you could prevent delirium. There have been applications of deciding which fluid you should give to a patient and how much and when. And to testify on the speed at which things are progressing, today we saw in JAMA the release of the OVIS reinforcement learning study, in which they used the model to try on retrospective data to find out when we should give vasopressin instead or in addition to noradrenaline. And the outcome was that compared to the population in the States, we should give it much earlier and probably also in higher doses. So these are things that are already out there. Now, you might ask, how does this improve my patient? And that's a very tricky question. So we did a systematic review on that. And first of all, what is striking to me is that the parameters that are used are very trivial, right? So for me, it's kind of hard to understand that this model will ever get up to par with intensivists as long as we don't have vision or smell or other sensors as input. But at least we can get somewhere. And we also see a similar development in reinforcement learning, and that's we are staying with the model development instead of moving down to the validation and implementation chain. So while that's the conclusion of the systematic review was that reinforcement learning very consistently outperforms clinicians when evaluated in large retrospective datasets. But there has no reinforcement learning algorithm ever been shown to improve patient outcomes yet. And for that, we need external validation data, code availability, and safety testing. Because for all these choices you can make, there are also an equal amount of problems. So the last 2.5 minutes, I will spend some time on how we can overcome these problems. So for example, we need not to rely only on models from the USA, because patients in Europe are very different. They're usually very much sicker when they are in the ICU. So that is why it's important that not only Amsterdam, but all of you start sharing your data. Because as you can see here, the outcomes for the reinforcement learning as a trade-off between PEEP and FeO2 were different between the States and Amsterdam. Also, it's very important to try to make these policies explainable. So we've done some work into a deep dive in the policies. You see the incremental value of those policies, and you can look at the purple dots, and that is where the model makes a very special trade-off, and you can inspect what's happening there. And very importantly, you can also limit the action space so that the model cannot go from 15 PEEP and FeO2 of 100 to extubation in one go. So there have been recent papers trying to do the same by something that is called pruning the action space. So you first learn by incorporating intermediate awards what actions are associated with favorable intermediate awards such as improvement in SOFA scores. So that's basically the way we are doing things in the clinic. And then after you have done cancelled out some possible actions, you train the whole thing again based on the sparse reward of mortality. So you will not lose that signal, but also stay close to the current clinical practice. We have done ourselves some experiments trying to put guidelines into the action space. So we learn the action space at the same time as the input from translated guidelines on mechanical ventilations as they are being put into the simultaneously trained model. But what is really needed is that every one of you is going back to their hospitals and start building a clinical artificial intelligence department. Because I think that's the only way to success. So a final thought, because I'm out of time. So it's very interesting to only look at regions, at states, where clinicians do different actions. Because when clinicians do the same action, we might as well assume that that is the best action, so we can take that out. And that will immediately improve the compute that is needed, so we can get to much better models faster. So I wanted to point your attention to some recent work by Paul Fester, who's brought this into a simulation lab. And by doing that, he looked at if clinicians were trying to stop unsafe actions, and they did. And he also found that they didn't bother much about explainability, so they did not look at the explainable AI section on that screen, but they did leave us, and that is my final slide, with an estimation of uncertainty of those recommendations. So I think it is already time to get reinforcement learning to the bedside, either with shadow testing or implementation with human feedback, or even adaptive randomization right now, because we're now a bit stuck. And I think we should just do it. And together we can. Thank you so much.
Paul, thank you. What questions do you have in the audience? Matthieu.
Thanks a lot, Paul. How do we test reinforcement learning? What's the next study we have to do if you want to do it together?
Yeah, so in my opinion, especially with now that JAMA, which I consider this a breakthrough, right? That a premier journal interested in intensive care medicine has now published a reinforcement learning study. So that means I think we're getting ready to do the trial, and the best way to do that, because some people might still worry that there is a little bit of insecurity or danger in following the advice, is to always have the human in the loop. So we should compare reinforcement learning plus intensivists versus intensivists, and we can then either give a clinician the choice of the two recommended, the two best actions with the highest perceived value, and let the clinician choose, or randomize between the two, or just give one action when we base the learning on what clinicians actually do, so that we get the model to mimic the best clinician instead of the average clinician in my unit.
So, Paul, I mean, in a sense, like, what are you waiting for, right? Because the next thing is a phase 2 safety and feasibility study or something, and then with some guardrails on it. There's a danger as well, though, that if you do a study and you find that your outcome doesn't work, that you kill what could be a very promising technology. So when do you know when it's a go, no-go to actually do a study? And what would your outcome be? Would you use a proxy outcome, a surrogate measure, or how would you do this?
Yes, and I actually think that the only way forward is not to linger too long in safety. I mean, of course, it has to be safe, right? I mean, don't get me wrong here, right? But I think the very fact that these reinforcement learning models learn and that they can also learn from the fact that an advice is ignored, I think it's and that the idea is that they keep updating and become better and better. So the first thing would probably be shadow testing, then implementing the algorithm, and leave the clinician completely free whether or not to choose, but just comment on the value of the advice, and then take it from there. But I think ultimately it's a matter of trust, and that's why I ask you to remember the first line. So when the reinforcement learning computer beat the world championship in the game of Go, it was by some move that nobody expected. So do we really know that our little decisions every day are the best decisions? Well, so I consider myself to be a very good intensivist, but I also consider myself not to know at all if I'm taking the best action every minute.
So, but I mean, a safety and feasibility study is randomized. It's powered for safety and feasibility rather than a particular outcome. Is that not the next step? And we did this with Cogitate, was not a reinforcement learning in TBI, and demonstrated it was safe. People did follow the instructions, because that's the other question: is will people actually follow the instructions? And then it puts you in a great place to actually do the full RCT, doesn't it? I think that's the next. Is that not next?
Yeah, I couldn't agree more.
Okay, well, let's do it.
Yeah.
Paul, a small question. I fully understand that we can assess a performance for a given algorithm in a setting and with a clinical question. I have difficulties all the time trying to understand what would be the outcome of a trial assessing an AI-driven clinical decision-making. Would you have the same outcomes? Would you consider that we can do non-inferiority? Would we go to cost-effectiveness? What is your perspective on that? I find it quite difficult to ask an algorithm to have outcomes such as mortality or such as sparing ICU resources. And I find maybe here a place for new designs and maybe new study design with adapted outcomes. What's your take on that?
So I think it's an interesting idea, but I don't know if it will be convincing to the people that need to use it. So, which is the audience here, I guess, right? So to dive a little bit deeper into that, so I think if you would consider non-inferiority designs, I think that would only be preferred if the intervention that you're testing will ultimately obviously be cheaper, right? So then it makes sense to be non-inferior, then you can implement it. But this technology is likely not cheaper, so I would actually go for classical outcomes in clinical trials because I am pretty convinced, based on what I've seen so far, that these reinforcement learning models can do better than most clinical trials that we've seen so far.
So then, would we consider new ways? If we take the imaging, for example, when we are assess the effectiveness of a system that compares to radiology, there is much more than effectiveness. There is an entire thinking on what will be medicine tomorrow, and how are we going to replace clinicians and maybe sometimes other machines. So is there a place here to consider new ways to address this? And I think that platform trials will be maybe more adapted than classic randomized control trials. And would we consider that sparing 2 days of vasopressors or 2 hours sometime if we are in the perioperative setting? So then we are there. What would be the discussion about that? Because this is all the time we consider that a trial is needed, and I fully agree. But then I don't think that it should be the same trial that if we were assessing treatment A versus treatment B.
So I agree to a certain extent. So first of all, as I said previously, I think the outcomes should be the ones that we're used to, right? So I would go for superiority trials with conventional clinical endpoints. But the way you do these trials. Yeah, so I've been thinking about this for a long time together with a large group of experts. So some would argue that reinforcement learning algorithms themselves, by having a behavior that tries to optimize their policy and find actions that they didn't explore yet, if you would trust it enough to let that free out there, then it would be a trial in itself, because the agent would suggest different actions by itself. But I think it's safer to have, as I told you, the human in the loop. So do randomization based on the best proposed actions. But we can do, as we have seen in adaptive platform trials, so reinforcement learning models, testing those would also be, well, I think they would likely benefit for design similar to that, also considering that they already have aspects of adaptivity in them by design.
Thank you very much, Paul. We need to move ahead. And I'm very pleased to invite Massimiliano Greco for the use of AI for medical education. Thank you, Massimiliano.
Thank you, Mr. Chairman, and thank you also to the Congress organizer, Professor Vincent and Tacconi, for inviting me. I work in Milan, in Humanitas Hospital, and well, I am a researcher in university and also an intensivist in intensive care. And part of my job is also to try to do a bridge between the doctors and the data scientists, also some educational courses. But we already have seen how is important artificial intelligence and how much we are developing it in the last few years. There are not published evidence, peer-reviewed evidence that I found, but there are studies saying that in 5 years, the US dollars invested around AI medicine will be about 200 billion, so something like 15 times more than what we have now. And also, we have dramatic opportunity, like, for example, in our website, you find that it may be that AI can reduce 50% of treatment cost and also increase the quality of care and improve patient outcomes when related, when used in medicine. And when we want to see whether it applies today, I have this survey from the last year in the UK. They sent about 30,000 doctors a survey on how much they are using AI yet in their practice. We can see that at least one on four doctor is already using AI in his clinical practice, maybe for the diagnostic and decision support systems, maybe for generative AI, but there is not so much, actually, because I thought actually it was more than just 1 in 4, but that is the results about this population. And if you go to more detail about that, 26% of these doctors are using that every day, and again, 1 out of 3 are using that once per week. If we go also to anesthesia and intensive care, more or less the percentage doesn't change. If you go to see radiology is 50%, because we have seen that with Azra before, that radiology is, of course, ahead in this field. But how are the doctors using that? How are they using for clinical practice, or are they using for AI for something else? Well, actually, we've seen that in clinical practice there are several problems in applying directly AI. We have a lot of promises, but not so much application yet. And Komorowski before did a very good presentation about that. What we can see here is that, I don't know how to point, but maybe like this. You can see here that only a few parts, I don't know, 55% is using that in their education. So education is something that actually is related with all us. We all want to improve our medical education. So I don't think that in this room, if you are in the Congress, you want to improve your education, of course. So it's something that actually is something that we do every day. So only 1 in 4 is improving their education using AI. But if you go to see how many things that AI should be used in the future more to improve their education, the percentage spikes up to like 80%. And also more training should be used in this population. So they want more training for younger doctors. And there are not so much revolution in the way we educate doctors. We have, we have something from 100 years ago, a century ago, like a standardization of education. We have the introduction of problem-based learning. Then we have the internet revolution. That is when we started to look at medical information, not only from books and published papers, but also on websites and something like up-to-date and so on. And it started in about, it's difficult to say when it started, but at about the beginning of this century. And then we have smartphones. Smartphone can help us having all the information we need in our pocket. And this is something that, again, in the last 10 to 15 years is coming. And then we have now, in the last 2-3 years, with ChatGPT for everybody, but also before that, the AI revolution. And I found this reference saying that AI tools can be a game changers in AI education, like the smartphone. But I think actually it's even more than a smartphone. Maybe it's more even than the internet revolution. AI is probably something that is going to change education forever in a very short time. And when we think about education and medical education, we have different categories. This is a review, again, from the last year, and only concentrating on AI topic in medicine. And we have 50% of the application in medicine dedicated to undergrad students. And then we have about 26% dedicated to graduate medical students, and nothing that is reported here about patient education. So most of the applications are actually for students, but and only a few part is dedicated to trained doctors. This is something that should be probably improved in the future. So coming to the concept, what can we really do with AI in our education, in our medical education as intensivists? There are several things we can do. We go through that quickly, from generation of new content to simulation to personalized training and to career guidance. Let me show you some examples. For example, how can we use large language models? For example, ChatGPT. there are several ways in which I use it, and probably you also use that. We can use that to summarize information, but we know there are several problems in that because information sometimes are not correct. There are hallucinations, and this is something quite risky. But for example, one interesting idea is to use ChatGPT for writing down educational material not only for us and for our students, but also for patient education. So helping us translating difficult concepts toward a more wider audience of not healthcare staff. And also again to provide medical information and to summarize very difficult concepts. Here in this study we have an example of how we can use that to test doctors and to test ourselves maybe. This is a prompt, so it's prompt engineering. How can we use AI to do a scenario for ourselves or for students? So there is an idea of a prompting. Please create a cardiac arrest scenario and quiz me on what proper next steps and managements I should do. And then please challenge me on the next steps, and then please what I do next, and so on. And actually, with this standardized prompting, you know that prompting is very important when we try to interact with the LLM. What we actually get is that if the overall system is working and we can have a feedback on what we are doing, sometimes ChatGPT, again, is hallucinating, sometimes doesn't follow instruction very well, sometimes it forgets to tell us very important things, so we are not yet there. But, of course, if it is supervised, it is something that we can use also to train our students and also ourselves. And this is from an ex-colleague of mine now working in Novara, in Milan, in Italy, sorry. And it is how we can use interactive voice, ChatGPT, to improve the quality of simulation. So they are using a Bluetooth microphone and a speaker near the simulation bed, and they are using that to interact directly with trainees during the simulation and improving the quality and interactivity of the simulation. Now you do that normally by Microsoft using a teacher, but you can also do that with AI. It's not yet, it's still a proof of concept, it's something they tried, but not yet in a full-scale simulation, but it is, of course, an interesting idea. And then again, I go back to another of the concepts. Simulation and prompt engineering is something very important. We want to have a very specific prompt, and so if you want to use LLM in your practice for trainees and for yourself, you have to be clear, have an organized structures and reproducible structures in your prompt, and then you can use that to increase your speed in producing cases and increase your reliability, and maybe switching from with the same cases from doctor to nurses to physiotherapists, with the help of AI and reducing the time needed from the case that you developed to our population. Then I'm not going to spend so much on this because before Frederic already talked about that, and there is the application of AI to guide us using ultrasound, for example, for cardiac imaging, and there are several studies that tested that, and we have seen an improvement in young trainees when using that and getting nearer to the scores of more expert ultrasonographers. Here you see very high percentage of accuracy in recognizing and the type of images, and so it's something that can be used to help students and young doctors to guide their probe toward the best view, and also to, we have seen that before, measure rejection fraction and so on. But again, we don't know whether in the difficult population of critical care, where you have PEEP and so on intervening with the images, this is something that can be used. And this is also something different there is also something different that we want to think about, that is that not simply giving doctors the LLM is improving their pattern recognition and their diagnostic ability. In this study on JAMA, for example, simply adding LLM to doctors, young doctors, is not improving their possibility of recognizing cases and making diagnoses on patients. So simply applying LLM on the other side not always work. There are positive examples on radiology, but also negative examples like this one, where nothing changes. But what is even more interesting for me is this thing here, which is personalized learning. you not only have something that learns and know a lot of things about medicine, for example, even if not always perfect, but we can develop systems that learns a lot and knows a lot about you, so they can triggers you on what you are, you know less, and also make you improve with a personalized training, personalized cases, and this is something that is probably going to revolutionize the future. This is not exactly AI, but it is advanced, augmented reality, and it's something in the middle between simulation and using these visors to improve the knowledge in the in the room that where you are studying, in the environment, and this is something that again will probably be used in the near future that we have to count on. And in the last part of this presentation, that was the application of some examples of application of AI toward doctors to improve their medical training, but also there is something that we have to know, and we have seen that in the survey at the beginning. We need to provide education and training also related to AI and to data science. So this was a paper we wrote last year, and with also Jean-Louis Vincent and Azra, and we were talking about the need of education of healthcare professionals, how to train them to utilize AI tools effectively, how to improve the AI-human interface, maybe better human-AI interface, to work very efficiently, and how to tell doctor to understand uncertainty, because with statistic and evidence-based medicine, you know that it was already quite difficult to reach an agreement on some of the studies. It's something that need a lot of statistical knowledge. The problem is that with AI, it can be even worse, more complicated. So we need to get there and have more and more training on that. A younger generation of doctors helping us on that. And this is another review telling us what we should train doctors on. So we should train younger doctors on data entry and curation, and also I would add data standardization like OMOP and so on. We should train them on theory and statistics, and also on algorithm interpretation. We should train them on ethics and drawbacks of AI, and also on the explainability of AI, because we can have a very complex AI system helping us in the near future, but if you don't trust them as a doctors, if we don't trust them because they are not well explainable, then they are completely useless. So we need to reach an agreement, reach a point in which doctors and data science providing AI models are together toward the same side. And then just an example from my hospital, nothing published, but we are, for example, introducing this course in informatics and data science in our standard medical degree curriculum. It's about 20 lessons in the fourth year out of 6 for our medical students, and it's something that we are doing now in the last 2 years for the first time. And then also the other side in which I'm involved, there are a lot of examples like that in other universities in America and the United States. United States are well ahead of us, but we have more and more master degree coming out to train data scientists to work toward doctors. So we try to train doctors toward data science and to train data scientists to work with doctors to bridge the gap between the two. And so to conclude, this is something that can be written in stone. AI will affect medical education and clinical training. Is already happening. Is not yet very structured, but it's something that is going to explode in next year. And there are several aspects, including summary of information, personalized learning, and so on, in which we can actually leverage AI. And this is just to conclude, probably the education with AI is this is the future if we want to exclude that. And thank you.
Thank you very much, and thank you for this last slide that is very special. We have time for comments and questions, and maybe, yes, please get close to your mic.
Thank you very much, Dr. Greco, for this here on your right side. Right.
Sorry, yeah. Okay.
Yep.
In the other side.
Okay.
Massimiliano on the right.
Oh, yeah, okay. Sorry.
Yep. Hello. Thank you very much for this excellent presentation. What I'm missing is a little bit the aspect of AI in cheating in qualification papers. So in Germany, we are noticing more and more perfectly written master thesis, doctor thesis, and so on. And I have the doubt that AI plays an important role in editing and writing these qualification papers. What do you think about?
Yeah, that's a very important theme. So the thematics, a very important topic. So I completely agree. I don't have an answer. We know that we can cheat with AI. We know that students are doing that. When you teach to students, they are actually checking real time your information to see whether you have said the things about that particular protein right, or if ChatGPT is something different from you. And so they are actually using that a lot in their life. In the last 2 to 3 years, we have seen an explosion of that. So really don't know in the future how it will go, but we need to find a solution to reduce cheating. That's the same also in publication. We know that we can make up data with AI, and we can make up a publication with AI, and so this the cheating problem, and it's something that actually is transversal to the whole world of AI and advanced reasoning and advanced information and knowledge.
Thank you, Massimiliano. One more question? Where? I didn't. No? So probably like many people in the audience, I interview students to come to medical school. Should I change my questions?
Yeah.
Should I change my questions that I ask the students?
Yeah.
Should I be selecting for someone different now?
No, so sorry, I didn't get it.
No, should we be selecting different people to come into medicine now, more seriously?
We do that already.
Yeah. That's well, the selection of students to get into medicine is difficult. You want to use AI on that? You can use AI.
No, I'm thinking making sure that we have a workforce that is properly equipped for the future.
Well, yeah, wow, that's very tough. I really don't know how it's the best way to have this. But there is no way, because we have to be equipped with that. There is no other way. We have to find a solution where doctors, also us, and also older doctors, more experienced doctors, are able to interact with AI, because it's something that is changing ourselves. It's like for the smartphone, of course, smartphones, younger doctors and younger people are using that more than us, but also we have seen that everybody is able to cope with that and to arrive to a solution. We need, in this case, more training, so we need to have transversal training, I think, across every age of education and doctors, going back to more senior doctors, and for me, no, there is no changes in the type of doctors we need. There is a needing change in the training.
Thank you. I think in the interest of time, we'll move on. Thank you, Massimiliano. Well, in that case, moving on, great pleasure to welcome Peter Nydahl to come and speak about how AI might assist us with patient diaries.
Thank you. Thank you very much for inviting me here. I'm Peter Nydahl, a nurse from Germany. And I'm talking about ICU diaries. We have a network for ICU diaries, and you will find a lot of templates and helps, studies on these websites. Any one of you in the audience who is writing ICU diaries? Yes, great. 1, 2, 3, 4. Some. Maybe, I hope, some more at the end of the lecture. How can I continue? Next slide. Do we have
No, it's this one. Aha.
This one, thank you. The green one is... Okay, got it. Thank you. After enjoying this lecture, you will know, cheers, how to write ICU diaries, how to apply artificial intelligence to ICU diaries, and hopefully how to apply human intelligence. We didn't talk about this topic yet, didn't we? So, back. Post-intensive care syndrome, you all know about this today. Long-stay patients on ICU suffer from several physical, cognitive, mental, and also social health impairment. Also, the family has a lot of challenges, and ICU diaries address mental and social health problems after the ICU. There are a lot of different ways of how to write ICU diaries. Here you see different examples. Most diaries are self-developed, printed. Some have some get to know me pages, who's the patient, what is the nickname, what are the hobbies, and so on. Some ICU diaries include photos of the family, some are handcrafted and really beautiful little piece of art. And the idea is that ICU diaries are written for patients with disturbances in their consciousness with more than 48 hours, long stay patients, like being in delirium, being sedated, being in coma, and they experience a lot of sometimes frightening experiences, and the idea is that the patient can read the diaries afterwards and understand what happened. A typical entry in a diary is written directly to the patient. Dear Mr. Smith, today you were admitted to the ICU. You suffered from a severe pneumonia. When you were transferred to us, you were coughing, gasping for air. You seemed to be panicked, shouting for your wife. I was holding your hand, trying to calm you, and so on and so on. So we try to explain the whole story, the ICU story, from the view of the patient, so that the patients can understand afterwards what happened. Also, the family is invited to write entries into the diary. It relieves their pressure, their tense, and it helps them to communicate with the patient, because they hope that the patient will be able to read what they have written 2 weeks ago or 1 month ago. There is good evidence for ICU diaries. It reduces PTSD, depression afterwards, it improved understanding of the experiences. We have better coherence for ICU diaries, and also on families, no impact on PTSD, depression, but improved coping, developing, maintaining relationships, and interesting post-traumatic growth, so they become stronger afterwards. And also the staff, the nurses, it leads to improved humanization of critical care, improved quality of critical care, and more self-reflection. At the end of the day, you are thinking about your shift, how could the patient perceive the situation, and then you reflect your own work. It really improves the professionalism of nursing. And meanwhile, during the last years, there are more and more digital ICU diaries. Post-ICU.com is a website from the Netherlands. Intensivkontakt is from Germany. Lifelines is from United Kingdom. Louis Rose is running this project. And LifeMap Diaries from Anne-Sophie Debut from France. It's an amazing website. And there you can write online diaries. And I think this approach is more and more emerging. By the way, all my slides will be downloaded on the EasyChem website afterwards. So I gave my consent, so you don't have to make photos and so on. So digital diaries. There was one paper by Zhu during the pandemic. And this was very impressive for me because they developed a new model. And you have the medical history and progress notes, of course, and then you can apply a language model and perform these medical notes to personalized reassurance texts for the patient. Mr. Smith, you are doing good progress. We hope that you will expand your spontaneous breathing trials, and so on and so on. And the idea in this paper was the doctor or nurse or whoever revise this transferred reassurance text, and then you just call the wife or the husband, take, I don't know how many seconds we need today, 20 seconds of the voice of the loved ones, and then you have a voice cloning model, and this voice would tell the story to the patient. It's an amazing idea. Technically, no problem. And we had the idea, what about developing ICU diaries out of this text? So we had the idea to ask ChatGPT, I'm sorry for it, and we had the idea to use the usual medical nursing documentation. Ask ChatGPT to write an ICU diary out of this usual documentation and hand it over to patients. So here are examples of real documentations by physicians and nurses, what you write into your documentation, of course. This is anonymized, no real patients behind, so we have no names. And the prompt was to ChatGPT, please convert this medical record into an entry in an ICU diary for Mr. Smith with plain, understandable language, empathic, so that Mr. Smith can understand what happened during his critical illness. Please add questions about his possible perceptions. We wondered what you perceived, and add wishes for well-being. And then we explained abbreviations we are using in our usual documentation. And ChatGPT wrote a nearly perfect diary entry for Mr. Smith. Dear Mr. Smith, I hope this message finds you in a moment of increasing strength and understanding. We want to share with you the journey you've been through during this critical period of your illness, and so on, and so on, and so on, in plain language. Remember, Mr. Smith, you are not alone in this. We are here every step of the way, and our goal is to ensure your comfort and recovery. Please feel free to reach out if you have any questions afterwards, and so on. So real empathic, and also questions for his perception were included, and so on. And so it took 10 seconds. It was crazy. So maybe it can save a lot of nursing time. So is ChatGPT the better diary writer? Very interesting. This is on the right above. You see a picture by ChatGPT. Please show me a picture how nurses are writing an ICU diary, and below is the reality, how it looks on our ICU when male nurses are writing an ICU diary. So we are asking, is this still professional care with empathy, interaction, and reflection when ChatGPT is editing ICU diary entries? ICU diaries are a very important way for nurses to communicate with the patient. We know patients are unconscious, they will read it in 2 weeks or 3 months or whatever, but can this relationship be replaced by a machine, by an algorithm? On the other hand, we in Germany and also in other countries, we have, take care of your phone, we have shortage in nursing resources, of course, and we don't have the time to write a diary for every patient. So maybe it's better than nothing. Better than have an AI written diary than nothing. But you know also ChatGPT transports pre-assumptions, discrimination, maybe abuse, and so on. We know that colored people in the United States have a higher mortality. So when it comes to this, maybe we have an increased risk for harm for patients using AI. So it's difficult. There are some studies who proved when you have artificial intelligence as a chatbot compared to real physicians, patients rank AI as more empathic than real physicians. So what will happen if patients would evaluate such diaries and say the AI-written diary is better than the nurse's diary? So it has really pros and cons. And we asked ChatGPT for this, and the answer was the idea of AI-generated intensive care diaries is promising, but it's important to find a balance between automation and human attention. The application of AI should complement but not replace human care. And this is a very, very good compromise to find a solution for AI-written diaries. Steamblot, the editor of Intensive and Critical Care Nursing, asked us to write a pro-con debate about this, and our arguments are, we had the job to write a pro position, and our arguments are AI-generated diaries save nursing time, save personal resources, of course, protect nurses' privacy. Some especially younger nurses say they have difficulties in writing diaries with patients coming too close. They standardize diaries. This is one aspect in research, because we don't know how many words shall be written to prevent one patient from PTSD. Some entries are over more than 3, 4, 5 pages. Other entries are rather short. We don't know how much must be written to prevent patients from PTSD. And here we can ask the ChatGPT, write every day 3 entries, each entry with 100 words. Would be possible. And afterwards we can evaluate if this is enough if the dosage of ICU diaries is sufficient to prevent patients from PTSD, and so on and so on. And the contra position was taken by Ingrid Egerø from Denmark. She's the godmother of ICU diaries, very difficult for us. And she said several ICU diaries concepts emerged over the last 30 years. So in the first beginning, diaries were written to support psychological recovery of patients. Then, especially in Scandinavia, they were written for nurses' emancipation and professionalism. Then digital diaries emerged, and Luda Kanatowskaja, who's also here in Brussels, she developed the idea of reading aloud diaries to sedated patients. Patients appreciate this. And now AI diaries. And she concluded perhaps nurses need more experience with the integration of real versus artificial intelligence before AI is put into general use. So maybe we have to think more about this approach. At last, ICU diaries are a simple tool to improve mental health of patients and families and improves quality of care. AI-generated diaries are tempting and hot, but raising a lot of ethically questions. We will come to this in the next lecture. And AI should be used with care in diaries or even only on demand. We named our publication Opening Pandora's Box. And in our conclusion, we don't want to open this box because we fear it can never be closed again. Our master student, Ella, who's first author of this paper, is now performing her master thesis for writing AI diaries, ICU diaries, for patients who never get in diary. So she will retrospective collect the medical records, use ChatGPT, and write an ICU diary afterwards out of the paper for patients who never get one. Oh, great. So it's an interesting topic. AI is a hot topic, of course, but maybe sometimes it's a little bit overestimated. We recommend not to use AI in writing ICU diaries. Thank you very much.
Peter, thank you very much. Any questions from the audience? I thought that was really fascinating. Did you find that you had to edit the diaries very much, or what about even getting the families to help edit the diaries or the AI output?
Families are most times open for ICU diaries. You just show them ICU diary, and they immediately understand the task, the topic of it. Yeah, we are writing today, so that the patient can read it afterwards. It stimulates hope for the families, and they really like it. They put photos in it. The children paint pictures, and so on and so on. During the last years, and especially during the pandemic, we switch a little bit to more digital diaries. So, most of us are using WhatsApp or Signal or whatever. You can export these stories in WhatsApp and print a book out of it. So more and more families started writing WhatsApp chats, sending it to the patient who was in coma, deeply sedated, but they know he or she can read the chat afterwards. So this was their kind of ICU diary.
Or maybe clone the voice and play it to them. It's really interesting.
Yeah.
Yeah, we are moving.
Thank you. Thank you, Peter. Fantastic.
Thank you very much.
And I'm very happy to introduce our last speaker, Professor Michel Gong from New York, reporting on the ethical issues raised by the use of AI. Thank you very much, Michel.
Thank you for the invitation. So I do have some conflict of interest, but none of them are necessarily pertinent to this talk, except that some of my grants did have to do with machine learning. So there are a number of different ethical frameworks that has been provided for guiding AI use in medicine. And many of them actually share certain components. But it may be best to put those ethical framework in the context of the different stages of AI model development as well as monitoring. just to have an understanding of where the challenges might come in. So in the pre-stage model is the what and the why. What is the thing that you're trying to build that you need to address in the ICU, and why you would need an AI to do this? The second is the one that you hear most about, which is the AI building and testing, the validation part. And then, as we heard earlier from Frederico and others, that the next one is one that we really should be seeing more of, which is looking at deployment and implementation and validating the AI model as it is being incorporated into the clinical workflow and the information system. And then the last is actually something that we almost never hear about right now, but it is actually has been incorporated into the FDA guidance for future devices that use AI, which is continuous monitoring for impact. How do you monitor the AI performance to make sure that it continues to improve outcomes and that it's still working well? Now, when we talk about ethical challenges, understand that the basic principles of bioethics in medicine is the same regardless of whether it is the pre-AI world or the post-AI world. And these principles of autonomy, beneficence, non-malfeasance, justice, confidentiality, and utility guides how everything that we do. What differs is what practices you adopt in order to respect those principles. So for example, when I talk about medical research, for example, we have adopted the practices of informed consent to respect the principle of autonomy. And we weigh the risk-benefit ratio in our proposals to respect the principles of beneficence and non-malfeasance. So let's talk about then some of the ethical challenges that may come up with AI. And let's start with a hypothetical case of an AI algorithm that decides and implements management of submassive PEs, okay? So not just to give you a recommendation as a physician that this is what you should do, but actually to say this is what should be done and to actually get it done and implement it. Now, if you say to me, Michelle, that's going too far, the machine taking over, understand that this is actually a bill that has been proposed and put forth by a representative in the U.S. And in this bill, he's suggesting to amend a current bill in the FDA. So down there is a summary. Currently, certain drugs may be dispensed only upon a prescription provided by a practitioner licensed by law to administer the drug. Under this new bill, they want to make sure that AI or machine learning algorithm given the same ability to prescribe and dictate the treatment, okay? So it's not that far off in terms of this hypothetical case. So confidentiality, that's simple. We need to have data security and privacy throughout this entire stages of AI development. But it really should start in the pre-model rationale stage. Because you need to have a plan ahead of time of how you're going to protect the information. But not only the data, but the output of the model. So let's say in our PE model that it predicts that the patient is much more likely to have a complication or have recurrent PE because they have probably malignancy-induced thrombosis. Well, they don't have the cancer yet, but if that information gets leaked out, would that compromise the patient's ability to get insurance? Okay. Autonomy. This is the principle for respect for the individual's right to make their own informed decision about their health care. And this starts in the pre-model rationale where we see if you have all the stakeholders, the patients and the clinicians, in what AI model should be developed and how. Is there an obligation to let patients know that their data is being used to develop and test these AI models? And then, during the deployment and implementation phase, what, if anything, should be taken in terms of informing the patients that they had an AI model be used in the decision about how the care is being provided? And then there's the issue about transparency and explainability. I'm not talking about the clinicians and the patients understanding the model and how it was built and how it came out with the results. I'm talking about whether or not there is an understanding of what the model is using to make those decisions so that you can have a patient and clinician discussion about it. So an example of that is, if you had a PE right now, if you had a PERT team in your institution, you can then go to a patient and say, you know what, we think you should have a mechanical thrombectomy rather than just heparin, because we had a multidisciplinary discussion and the clinicians have brought up the risk and benefits, and we thought that this may be best for you given these kind of circumstances. Let's take away the PERT team. You have the AI algorithm. How do you actually have that same decision making with the patient if you don't know why that model gave you that information? And then with regards to monitoring for impact, so do the clinicians and the patients have the ability to go against the model? And if so, will this be tracked and fed back to the clinicians so they understand those consequences of those decisions when they go against the model? And again, that builds trust too. Because of data drift, will the patient and the clinicians have a right or the ability to know how the model is performing 5 years down the line when it comes to them, when it was developed a while ago? And how do you even inform them? For a lot of these reasons, you hear people talk about a human-centered AI models or making sure that there's human oversight. And that's all practices to try to respect autonomy in the bioethical principle. And this is consistent with what patients want. In all qualitative studies looking at patients and perspective in terms of the use of AI in their care, many patients, almost half, are comfortable with the AI making recommendations about medical treatment. And even a third of them would be comfortable if AI is being used to administer the prescribed medication. But that's administered, like, an AI insulin pump, for example. That's not the same as they saying that they're comfortable with AI making the decision to prescribe it. In fact, actually, 63% expressed concern about the AI's lack of humanity and would not want AI to be making medical decisions for them. And they all unanimously agreed that the decision of treatment should be by the physician and the patient. Well, what about beneficence? The attempt to maximize benefits and minimize the risk for best interests of the individual. And non-malfeasance, to avoid unintentional or intentional harm. This starts in the pre-model stage. What if there is a value collision? What if my hospital system wants to develop an AI to understand actually which patients are going to have the longest length of stay so that maybe they don't want to take those patients on transfer? If you have the patient as a stakeholder, they might say, no, I don't want you to build that model. Okay, I want to be able to have maximal abilities to get the care that I want. Reliability, and this is what we've been talking about with regards to how we should do clinical trial. Is the model reliable? And is it reliable and safe in different environments in which it's going to be deployed? And then is the data or the evidence that's being used to train the model accurate, current, and robust? And then there's the issue about the benefit. Okay, does it actually improve the outcomes? And that's where we're going to need the clinical trial. But also actually in terms of monitoring for impact. Once you have deployed a model, who's going to continue to monitor it for adverse events? And how? And what's the accountability? Like right now, if there's a medical mistake, a lot of us will have these committees within the hospitals that will review the mistake, see what the problem, have a correction action plan, and maybe require some education, some change in the order set. But what do you do when it is an AI algorithm that's made the mistake? Who do you report to change? Justice, and we've heard lots about this with regards to AI. How do you ensure a fair and equitable sharing of both the benefits and the burdens of the AI model? And here's where there's a lot of inherent biases that exist on every stage of deployment. And these biases, I don't know that we're ever going to get rid of biases. Because, we as clinicians, we all know there are biases with regards to human behavior. The key here is whether or not we're aware of them, whether we're measuring them, and we're trying to safeguard against them. In the pre-model stage, that's the exclusion of stakeholders. And then there's environmental bias. If you don't even have data on race, okay, and actually many EHR systems list a large number of their patients' race as other or unknown, you're not going to be able to even know if you have equity problems. Algorithmic bias is safe and reliable in a setting similar to where it was developed. If I develop that PE model in my institution where I have 24 hours a day access to mechanical thrombectomy with skilled people, well, what if they use this model in one of my other sites that has less expertise in it? Will it be as effective? Exclusion bias, some people are being excluded from the development of this model. And then I'll talk about evidence bias in a second. And then there's a digital divide during deployment. Are the institutions that are going to most benefit also have the resources to deploy? Are the elderly patients that may most benefit be technologically advanced enough to be able to engage and use the AI? And then the monitoring. And I'll talk a little bit about equity audits and reinforcement bias. So here's an example, my PE model again, right? We know that Black and rural patients have higher mortality from pulmonary embolism, even with the same severity. And that Black patients with PE are younger, but they're more likely to have severe PEs. But when you look at actually what their intervention is, it turns out that Black patients were less likely to get any intervention. And that's especially true if they have a submassive PE. Now, these studies also show no racial differences in terms of in-hospital mortality. But here's the problem. When it comes to submassive PE, I'm not sure hospital mortality, such short-term mortality, is really the outcome that we need to look at, right? What may matter is long-term mortality or recurrent PE or functional status from having a more aggressive thrombectomy or lysis versus actually just anticoagulation. And this is where evidence bias comes in. If I were to build a model focusing on only in-hospital mortality, then there may be reinforcement bias that the model will keep telling me with Black patients that it's okay not to use the more aggressive treatment. But that's evidence bias because currently that's based on evidence that is short-term and mortality and not really reflective of this patient population or that disease. And then the last principle is utility. And this has to do with the benefits of the AI model should outweigh the potential risk and cost, and that's true of the society. So I struggle with this because I do use ChatGPT and AI models. But, you know, 1 year's worth of ChatGPT use uses so much energy that it can power the entire country of Australia for a day and a half. And that's why we have these large complexes, and look how many of them across the world that there is. And if you're going to build and train an AI model, it causes even more energy. So in summary, the principles of ethics in medicine is the same, whether it's in the pre-AI world and the post-AI world. And what matters is that we need to plan ahead. We need to look at where we're going and where we're jumping so that we have some kind of framework to look for some of these challenges and when we might fall short. The problem, however, is that AI is exponentially growing. It's basically putting a rocket on that skier and making it hard to see ahead. But we need to because the AI in medicine have far-ranging implications beyond medicine. And with that, I want to thank you for your attention.
Thank you very much, Michelle. We have time for one or two questions. Yes, please, if you can get close to a mic. Thank you very much.
Thank you very much, Michelle. I'm an early UK doctor in my career, and I'm talking about the AI-human interface. My question is whether there's a simple way, like a traffic light system that we have on food, for me to know if I should use an AI as a tool or as a peer, like shoulder to shoulder, or as senior guidance, like an instruction?
So, tough question, because I'll tell you, it would be great if you can have a kind of an AI guardian angel is basically what you're asking, right? Somebody who can actually help us figure out if this is the right tool to use. I would say that we don't have that right now. But I also would say that our previous talk on AI and medical education, that's where I think we need to actually start imbuing it, is to not only teach the medical students actually about, how AI is being used and what it is, but actually how to use it as a tool, when it is right to use and when it is not. And right now, I don't know of any simple tool to help you with that.
Thank you.
If there is another question. I was, Michel, very interested by the bias that you reported on the algorithms, and there are many examples. One of the risks in the ICU is mostly to have machine learning approaches, learning from old databases, not representative anymore of what is the ICU today.
Yeah.
The corrections themselves raise some ethical issues if we are trying to adjust or to take this into account. So what would be the solution for that? We know that any algorithm has bias based on what he learned, that we can train the algorithm as much as we can, but we will still have some biases based on the population where we are, and that's different in the US than in Europe, etc. So what would be the solution, if not just accepting this and trying to move ahead and taking it into account?
So I think the only way to do that is to actually have auditing. So, when we develop a medical device, okay, in the FDA, it is actually a requirement that the manufacturer has to demonstrate that the new version of the device or the next year's device operates comparable to when they had first actually got it approved. That's part of actually the continuing audit and review and monitoring of performance, right? Similarly, when we have a drug that's approved in a clinical trial, there has to be a phase 4 to see actually how it deploys in the general population and if it's still safe, which currently needs the same for all AI models. But where you're getting at is that we don't yet know how to do that, okay? But it does need to be done, and it's being asked for now, I think, by the FDA, but also I think by the European Union, that there needs to be this continual auditing, which means that if your institution or the vendor, whoever you're purchasing that, has an obligation to continue to collect the data afterwards and analyze it and report it and update their algorithm, or it may be that they have an obligation then to retrain their model every year or two. The exact method and how they are going to be enforcing that is still yet to be decided.
Thank you very much, Michel. I think that we had a wonderful session and we learned a lot on AI. We wish you a wonderful conference, continuing here and elsewhere in this conference. Have a great day. Thank you.
Microphone is, and now microphone is working. Okay, thanks. So no industrial disclosures, but academic. I was a co-author of BMG Rapid Practice Guidelines on the topic, which I will also refer to in my presentation. And when preparing, it was quite striking for me to find out that 1/4 of adult population in the world, as much as shown in this systematic review, might be on PPI, receiving proton pump inhibitors daily at home, all adult population included here. And of them, 25% received it for more than a year. So it's a huge amount of people around taking PPIs. If we look at the data in the ICU, then studies say it's 50 to 95% of ICU patients who receive stress ulcer prophylaxis. And we are coming back to mechanical ventilation as one factor and also important for studies. And studies show that around 40 to 60% of all ICU patients are mechanically ventilated. And if we look at the polypharmacy shown in this actually small study in 105 patients, then we see that these 105 patients received PPI for 501 days in total. So it's a lot. And actually it's the largest proportion. If you take all antibiotics together, then it is more. But no single antibiotic group is more. So a lot of people are under PPI in the ICU and outside. If we look at the recent guidelines, then they said that, coagulopathy, shock, and chronic liver disease are risk factors, that clinicians should administer enteral nutrition to avoid or reduce clinically important bleeding. They said that patients with risk factors should get stress ulcer prophylaxis, and also patients in neurocritical care. And then they had two statements that were unclear to me, because actually they added their enteral nutrition, but you could as well take out the enteral nutrition from this, these statements, because they say give if there is a risk and don't give if there is no risk. And enteral feeding is just put there in between. So actually they don't change their suggestion based on enteral nutrition application. They had two important statements, that low rather than high dose should be used, and that stress ulcer prophylaxis should be stopped if the risk factors are no longer present or patient is discharged from the ICU. And now I come to the guidelines where I got conflict of interest. And we then actually put mechanical ventilation with enteral nutrition below the line to indicate the need for stress ulcer prophylaxis. So we actually had less strict suggestions or statements to apply stress ulcer prophylaxis. And we also tried to calculate, statisticians didn't like it, but we still calculated also absolute risk and said that if the risk is less than 4%, then you should not apply stress ulcer prophylaxis. And here are the results from this guideline, and you see that actually the risk of important bleeding was mainly reduced in these patients who had higher risk. So you had to have higher original risk to reduce the incidence of bleeding with prophylaxis. And there was also a non-significant but a trend towards having more pneumonia. If we look at the recent large study, including mechanically ventilated patients, revised study, and applying stress ulcer prophylaxis versus placebo, pantoprazole, so PPI versus placebo, they showed that there was less GI bleeding with stress ulcer prophylaxis, which is actually shown in all the studies and all meta-analysis. And it was 1% in PPI group versus 3.5% in placebo group. And if you now look here, then the bleeding was most reduced in more severely ill patients, so with a Apache score above or equal to 25. But if you look at the results on the 90-day mortality, then you see the opposite. The mortality seems to be decreased in the less severely ill patients, and there is a trend towards increase in more severely ill patients. And here, up here, you see also, does it up? Sorry. Don't know. Ah, yeah. You see that it is true. 1/4 of patients came, or even more, came already with PPI in the ICU. So they had the drug already when they were admitted to the ICU. And to continue here with less severely ill and more severely ill patients, then SUP ICU or earlier trial made a post hoc analysis and took only the subgroup of patients with SAP score more than 53 and showed that in this score PPI was probably harmful. And if you look at all these other subgroup analysis in this population with SAPS 2 more than 53, then there was nowhere benefit. Everywhere placebo was better. And then there was also a meta-analysis recent, which said clearly PPI reduces upper GI bleeding, but it doesn't reduce mortality. So the drug is effective against GI bleeding, but it is not effective against the ultimate goal. However, there is possibility that mortality is increased in most severely ill patients. And this is a worrying message. Also, another interesting post-hoc analysis of the ICU study was on enteral nutrition. And it was shown that PPI with enteral nutrition reduced the bleeding more than PPI without enteral nutrition. Enteral nutrition itself reduced it also very well. But if you look then at the mortality, then if PPI was applied to patients receiving enteral nutrition, then mortality seemed to increase and not decrease. And the authors concluded that PPI with no EN had little effect on mortality, whereas PPI with EN was compatible with increased all-cause mortality. The confidence interval you see here includes 1, so it is not, and it is a post-hoc analysis, of course, and people were not randomized to receive enteral nutrition or not. So these data need to be taken with caution. However, now we come to the next topic, which is PPI versus H2 receptor blockers, and you see that PPI might be more effective to reduce bleeding. One large peptic trial showed more or less similar outcome. However, if you look at the different Apache groups, so different severity of illness groups, then it seems that PPI might have increased mortality in patients who were more severely ill. One large database analysis with propensity score matching in patients with major cardiovascular or cerebrovascular events showed actually similar results, that PPI might be not preferable or even increase relative risk of 90-day mortality compared to H2 receptor blockers. And it was in adjusted analysis. There were several editorials written, one already now 5 years ago, and they said that most patients would probably exchange a small increased risk of upper GI bleeding to avoid a therapy that might increase their risk of death. This was after SUP ICU post-hoc. However, now the more recent one, suggested to use, or as a possible approach, to apply stress ulcer prophylaxis in all these patients listed here, because these were the inclusion criteria in the SUP ICU and REVISE trials. And here you see that actually H2 receptor blockers are kind of disappeared. We are talking now only about proton pump inhibitors. And I have trouble to agree with this statement that the author said that machine learning models could help to find in whom the preventing GI bleed is possible with the lowest likelihood experiencing increased risk of death from prophylaxis. So we are talking about prophylaxis that didn't result in decrease in mortality, but may increase mortality in some patients. And here is what patients would say about it, very nicely done with interviews and kind of consensus process. And patients logically say, I want to survive, I want to go home as soon as possible, and I want to not to be disabled. And this is very realistic. Of course, if you ask them, then there were some concerns about interventions that we do. Adverse events with PPI, pneumonia, we said actually in a meta-analysis it is not shown that there is higher risk of pneumonia or Clostridium difficile. However, Again and again, some studies suggest that there might be, and here a study with PPI versus H2 receptor blockers showed less ventilator days and less ventilator-associated pneumonia in H2 receptor blockers. And if we look at the Clostridium difficile, then no difference shown in ICU patients in meta-analysis. However, there might be a problem of long use, and if you think how long the patients at home use and how many patients go to the ward from the ICU, then this might be relevant, because more than 14 days of use increases the risk of Clostridium difficile infection with PPI use. And this was also confirmed in these subgroup analysis, and also confirmed in sensitivity analysis, where they excluded some groups of patients. And now we come to inappropriate prescription that is probably happening every day in our ICUs, and this study showed that there were more than half of patients receiving stress ulcer prophylaxis without indication. And very importantly, here is the ICU, patients with stress ulcer prophylaxis. Here is ward after ICU discharge, and here is that they went home with prophylaxis. And this is a large amount, so probably we as intensivists contribute to the large proportion of adult patients receiving PPIs at home. And this is important also because it is associated with higher morbidity and mortality if you use PPI longer than 8 weeks after discharge, as shown in this adjusted matched study. So to come to conclusion, stress ulcer prophylaxis is still a place. I don't dare to say no, so I say probably yes, but it needs to be individualized. And it's also not realistic to stop at this time point. 90% receive stress ulcer prophylaxis to reduce from 3% to 1% of bleeding, and there is no effect on mortality. However, most severely ill patients profit the most in reduction of bleeding, but at the same time increase mortality. And patients receiving enteronutrition at the time receiving PPI, less bleeding, but increased mortality, maybe, possibly, probably. And negative influence on GI function that we will look at in the next talk is also should be considered. And polypharmacy in the ICU may be a relevant factor, so maybe we need to consider this. But it is no consensus how we could individualize, as you saw also in the guidelines. However, guidelines said stop when patients leave ICU, and this is already something good that we could do, and definitely stop when leaving hospital. However, guidelines should probably help practitioners to reduce, because if the patient dies when receiving PPI, nobody says that it was because of stress ulcer prophylaxis. But if the patient develops GI bleeding without receiving stress ulcer prophylaxis, then the doctor will be blamed. So guidelines should help doctors. Thank you.
We have a couple of minutes for questions. Just raise your hand if you want to ask a question.
Yeah, another important point is drug interaction of PPIs, particularly with CIP C29. Yeah. If someone is having antiplatelet agents like clopidogrel, the efficacy of clopidogrel might be compromised. And if someone has, say, PCI and on-clopidogrel, they might land up with a cardiac event as well. So barring most say something like rabiprazole, even pantoprazole has got significant interaction. So another class of agent is available in my country now, which is potassium competitive acid blocker, like vonoprazan. They are more prompt and they have no action with CIP-C29. Any thought on that? Is it available in your country? I don't know.
No, of course, mechanisms are really important, and we should look into mechanisms, what cause harm. But we are talking about prevention that does not seem to improve patient-important outcome. So actually, we should also, of course, look at the mechanism and other drugs. But first, we should, in my opinion, reduce the overall use. And this can probably be done rather fast. But I absolutely agree the mechanism should be investigated.
Thank you very much. Excellent talk. Three kind of observations or requesting comments. If, say, half the population is on PPIs without really any clear indication, because they're obviously not benefiting from gastrointestinal prophylaxis, what's the monetary cost of this intervention? What's the carbon cost necessary to pay the money in order to buy all these PPIs? And then finally, where do all these things go after they're excreted from the bloodstream? Because they probably end up in the drinking water and wherever they go. Can you comment, please?
Absolutely, I can just agree. These are all the aspects that also should be considered, and I'm absolutely in favor to reduce polypharmacy.
Thank you so much. All right. We have our next speaker now, Dr. Evangelos Bourboulous from Athens, who's going to talk about probiotics to prevent WAP.
Well, thank you very much. I would like to thank the organizers for inviting me to, it's the third year in a row where I'm delivering that talk on ventilator-associated pneumonia and how probiotics are able to prevent ventilator-associated pneumonia. And every year it's impressive to see how things are changing, how the concept of the publications there are changing. And allow me to walk you through all the recent evidence and present you also some data coming from my group. So the first thing that is the major point of understanding on how probiotics may impact the incidence or not of ventilator-associated pneumonia is that, first of all, we need to get rid of, I don't know if it's the correct verb, or to change our way of thinking, that lung is not a sterile cavity. Lung has microbiota. And in order to develop VAP, this microbiota needs to be modulated. What are the factors which modulate microbiota? First is microaspiration, and it may well be the case that what you presented earlier about PPIs or H2 blockers may have an impact on this. The second is the gut-lung translocation, and the third is the antibiotics the patients are receiving, how this is changing the microbiota, but also the immune response. So what has been published so far provides evidence that probiotics are able to modulate either all three of these pathways or at least one of these pathways. So if you look out there, you will see that there are plenty of meta-analyses. Meta-analysis of small-scale randomized controlled trials. Yes, indeed, there are randomized controlled trials. And the idea in all these trials is that probiotics are given through enteral feeding. There is also a comparator group, which in most of these trials are placebo. In other terms, the vehicle of the probiotic preparation, and in some cases they're also a symbiotic. But very few of these trials, they give a clear-cut message. As you see, there is heterogeneity in response. But if you add all trials together, the diamond which is at the end favors probiotics. In other terms, the answer to the question, each of these trials, these 11 trials, which are in this most recent meta-analysis, try to provide, does administration of the probiotic reduce the incidence of VAP or not? It is obvious that none of the trials on its own can deliver an answer, but if you add them all together, then you get a yes. So the first question is, I was very happy to listen to the previous speaker saying that the decision to give PPIs or not should be individualized. And as I was looking at the program of the conference, many of the sessions and many also of the talks are dedicated to a precision approach. So, where is precision within this heterogeneity? First of all, we speak about probiotics. What probiotic means? Probiotics in general. For instance, if you have a preparation of 1, of 2, of 6, is the same thing. And what should be inside the preparation? And symbiotics are actually the probiotics with a type of organic vehicle. Does this make part of this heterogeneity or not? But probably this can be considered to be part of the heterogeneity, and allow me to address you to remind you what I addressed in the very beginning, that probiotics are live microorganisms. And from the moment they are live microorganisms, they modulate the immune function. And it's obvious that the modulation of the immune function would be completely different if there is 1 species, 2 species, or even 6 species on the preparation. And actually, if it's completely different, if we speak about Saccharomyces or we speak about lactobacilli. Allow me now to show you a prospective study. In this prospective study, patients who developed VAP and comparators were enrolled. Here, if you could deep dive in this publication, you will come across the major concern in all these trials. In all the trials which were included in the meta-analysis, you could very easily debate and challenge each of them by just one simple question. How is VAP defined in each of these trials? And ask yourselves, how do you define VAP? Do you all agree that with your colleagues, as you do rounds in your ICU, that a patient who's considered by your colleague to suffer from VAP or to develop a VAP indeed has a VAP and another source of infection? So from this tree, they ended up with definitive cases of VAP. And then they analyzed the stool microflora. And they ended up that there are 3 species who, if they are enriched compared to the controls, they prime VAP, and there is 1 which protects from VAP, and actually what the authors are suggesting is let's get that one and let's make a probiotic out of it. The second is the effect on lung microbiome, and this is a small-scale randomized controlled trial enrolling critically adults which were enrolled without infection, and likelihood to stay on mechanical ventilation more than 72 hours, and they are randomized into getting a probiotic every 12 hours until ICU discharge, and those who are getting a comparator. Actually, what was really important in this study is the type of intervention, which has not actually much to do with the probiotic per se. It has to do with the concept that they collected BAL before the intervention, and they repeated sampling 5 days later. And look what they got. These are the operational taxonomic units. These are the main species. Each band represents a different species. There is not really a reason that you recall what are the name of the species, but just, if possible, contain the visual difference here in the control group between day 1 and day 5, and you see that all of a sudden the red band goes up, protobacteria increase, and all of a sudden the richness of the entire microbiota of the lung goes down. But if you look what's happening in the probiotic group, there are no differences between day 1 and day 5. And actually, if you compare the Shannon Diversity Index, which is a metric of the diversity of the microbiome, on day 5, between the comparator group and the placebo group, you see that the treatment group managed to maintain the diversity of the flora. And then all of a sudden there is that publication for which I'm certain that you all are aware of. It's coming from the States, the largest publication ever, almost 2.7 thousand patients. They are randomized to receive blind treatment with placebo probiotic or one species of only in the preparation, Lactobacillus rhamnosus. They have 1 billion probiotics per capsule. They administer that twice daily, up to 60 days, and in patients who are under mechanical ventilation for less than 72 hours, the patients are not immunosuppressed, they are not under immunosuppressive treatment, and the primary endpoint is the incidence of VAP. And the result, 21.3% incidence in the placebo arm, 21.9 in the Lactobacillus rhamnosus arm, actually no difference. And taking into consideration how large the trial is, someone would say probably we should be against probiotics. But if you compare what was the situation at baseline in these patients, you see that all of them, they are already infected on the day of start of the study drug. They have pneumonia, 60% of them, 10% bacteremia, 7% skin infections, and 13% they have sepsis. In other terms, the lesson we'll learn is that you should not give probiotic to prevent an infection in a patient population who's already infected. And this is where precision approach starts. Now, let's try to make it even more precise. These are adults. They have trauma of head, and at least one more organ. They're under mechanical ventilation with expected duration of more than 10 days. The expected survival is more than 15 days, and they are randomized. And they get from the nasogastric tube or through the gastrostomy, placebo every 12 hours for 15 days, or a preparation of 4 probiotics. Every capsule contains Saccharomyces boulardii, Bifidobacterium lactis, Lactobacillus acidophilus, and Lactobacillus plantarum. Each of these species are more than 1 billion. The treatment is twice daily for 15 days, and the follow-up ends on day 15 with the endpoint of the incidence of ventilator-associated pneumonia. The real point here is who are the excluded patients. Look one by one who we exclude. Patients under immunosuppression, under hematologic disease, a medical history of prosthetic heart valve or vascular graft surgery, cardiac trauma, oropharyngeal mucosal injury, recent history of sinusitis and respiratory tract infection, obesity, administration of probiotics before screening. In other terms, all these are patients which narrow down the patient population which will receive benefit. And then the question comes, look, which are the patients who we treat? Actually, their mean age is around 40. They don't have real comorbidities. The SOFA score, because of the underlying condition for which they are admitted in the ICU, is around 6. Their Glasgow Coma Scale is around 10, which is anticipated since these patients, they suffer from head injury. You see that there are no differences in co-administered antibiotics, and as a matter of fact, when I discussed for the first time this data with a friend coming from the Netherlands, he would say, okay, so you give a type of SDD in your patients, and also there is balance in the type of feeding. The question here is how we define the primary endpoint, the incidence of VAP. And in order to do that, we decided that we will name VAP all patients who meet all criteria of all type of studies for VAP, and to make that very strict, taking also into consideration the positive BAL culture. With that in mind, this is the time until progression to ventilator-associated pneumonia. And actually, 28.3% in the placebo group compared to 11.9% in the probiotics group develop ventilator-associated pneumonia, meaning that there is a relative protection of 63%. And if we go to the multivariate analysis, which takes into consideration comorbidities, severity score, SOFA score, APACH, and SAPS-2, you see that the only variables which prime ventilator-associated pneumonia are CCI, the Charles's Comorbidity Index, which is positively associated with the incidence of VAP, whereas probiotic treatment is the only variable which protects from that. Look, some of the secondary endpoints as we move along, the SOFA score goes down, and if you look at the microbiology of our patients, the major pathogens in my country are gram-negatives, Acinetobacter baumannii, Pseudomonas, Klebsiella. These are the main pathogens for which patients receiving treatment are protected. Two more secondary endpoints, the time until stop of vasopressors. So this favors the probiotic group. The same applies for the time to alive ICU discharge and hospital discharge. With that in mind, I believe that prevention of ventilator-associated pneumonia using probiotics is a very precision strategy. It requires to fully define the characteristics of the host, but also, by definition, the patient should not be at an infection state when probiotics start, so it's prevention in patients without infection, and also, it's very important, what are the species which are administered. All trials which demonstrate benefit, they deliver preparations with at least 2 to 3 different species, and most of them being lactobacilli. Thank you very much for your attention, and thank you for the kind invitation.
Thank you for a nice talk. We have time for 1 or 2 questions from the audience. Okay, well, I have a question for you. Obviously, the data needs a lot of interpretation, as you rightly put it. There is definitely some level of precision that needs to go into selection. Has there been any data on a cost-benefit analysis that has been done, or is there any cost considerations of usage of probiotics at all?
Well, personally, I'm not aware of any of this data. There are some anecdotic publications, but they are not in medical journals, so I would refrain from presenting them.
Sure.
I actually have one other question as well. You presented the data from that last trial on trauma patients, many of whom may have more intact guts than a typical medical patient, less edema, perhaps less ischemia. How does that factor into the efficacy of probiotics?
Well, that was something which was not captured on the data, but it was expressed through the severity scores, and this actually was the reason why it was predefined that the multivariate analysis was needed, taking this taking age, SAPS-2, APACH, SOFA, and CCI into consideration.
Okay, great. Thank you so much. Thank you for a great talk.